Good evening, friends and colleagues. Best of Ash, an ultimate day, Saturday, day 6 of this marathon webinar brought to you by Mumbai Hematology Group, managed by Mice Ideas. 3 lectures today. The first one, Posaconazole Delayed Release Tablet for prophylaxis against invasive fungal infections in hemato-oncology. To be delivered by Dr. Biju George, Professor, Department of Clinical Hematology at CMC Vellore, supported by MSD. Lecture 2 is on ITP, what's new, to be delivered by Dr. Cindy Neunert, Associate Professor, Pediatrics, Section Head, Pediatric Hematology at Columbia University Medical Center, New York, supported by Alkem. Lecture 3, BRAF V600E mutation in hairy cell leukemia from bench to bedside, to be delivered by Dr. Falini, Director, Institute of Hematology and Bone Marrow Transplantation from Italy, supported by MedGenome. I thank Mr. Subrata Roy and team from MSD, Mr. Abhijit Nazare and their team from Alkem, Mr. Vipin Monga, Mr. Praveen Singh and their team from MedGenome for supporting our academic activity, Mr. Rajesh Sharma, Mr. Kalpesh Pambar and the team from Mice Ideas for managing these shows, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Manisha Madkaikar from ICMR NIIH Mumbai, our guest speakers, Dr. Biju George, Dr. Cindy Neunert and Dr. Falini, all our discussants who are themselves eminent hematologists or hemato-oncologists, and you participants for sparing your every evening for this week, including this Saturday evening. To introduce our discussants, and we once again have a galaxy of them, they're all stars by themselves. Dr. J.M. Kungar from Vardhaman Mahavir Medical College, Delhi. Dr. Chandran Nair from Malabar Cancer Center, Thalassery. Dr. Satish Kumar A from Columbia, and now I understand it is taken over by Manipal Group of Hospitals, Bengaluru. Dr. Neeraj Arora, his Lab Director, Molecular Biology, Unipath, Ahmedabad. Dr. Nayaz Ahmed from Rajiv Gandhi Cancer Institute, Delhi. Dr. Prashant Bhatt from KMC Hospital, Mangaluru. Dr. Parimal Sarda from Vedanta, Ahmedabad. Dr. Preeti Mehta from Sir H.N. Reliance Foundation Hospital, Mumbai. Dr. Neeta Radhakrishnan from Postgraduate Institute of Child Health, Noida. Dr. Ritika Khurana from Vijayawada Hospital for Children, Mumbai. Dr. Aniket Rayani from Cure Hematology Oncology Clinic, Ahmedabad. Dr. Tushar Sehgal from AIIMS, New Delhi. Dr. Amita Saraf from Sir Gangaram Hospital, New Delhi. Dr. Priyanka Agarwal from Institute of Medical Sciences, BHU, Varanasi. Dr. Madhvi Madali from CMC Vellore. Dr. Vijita Datta from ESI PGI MSL, Kaliktala, Kolkata. Now it's my pleasure to introduce our chief guest of the day, and we are blessed by her kind presence. She's going to inaugurate our webinar today. She's my friend and colleague, Dr. Manisha Madkaikar. You all know her. Huge name in the field of hematology, especially on the research side. She is Director and Scientist G, ICMR, National Institute of Hematology, situated in KEM Hospital Campus, Mumbai. After completing postgraduate training in internal medicine from St. G.S. Medical College, Mumbai, that was way back in 1997, she joined ICMR NIH as a research scientist. Her areas of interest include primary immunodeficiency diseases, hemoglobinopathies, inherited marrow failure syndromes, and hematopoietic stem cells. She received training in primary immunodeficiency diseases from the prestigious Great Ormond Street Hospital and the Institute of Child Health, London, in 2007 under DBT International Fellowship. Her laboratory was the first one to establish the state-of-the-art diagnostic facilities for primary immunodeficiency disorders in India. Her center at NIH, together with B.J. Wadia Children's Hospital, Mumbai, have been recognized as a center of excellence in primary immunodeficiency diseases by ICMR. She is founder member and past president of Indian Society of Primary Immunodeficiency Diseases. Over 110 publications in peer-reviewed journals and chapters in 10 books. Well, we are blessed by her kind presence. I request her to address us and inaugurate this webinar.
Good evening, everybody. First of all, sir, sincere thanks for inviting me today as a chief guest for this Best of ASH series organized under the aegis of Mumbai Hematology Group. Indeed, it is a great pleasure and honor to be part of this activity. As sir has already said that there are three international speakers, national and international speakers talking on different topics. What I must say is sir manages to get best of the speakers with great personal experience as the guest faculty for all his events that he organizes, and over the years that we really look forward to the lectures given by them. What is more important is, along with them, there are a number of discussants which are also enthusiastic and experienced hematologists from all over India. And as you have already seen, there are a galaxy of these Indian hematologists from different parts of the country that are there today. The discussion that follows actually most practical and important discussion or topics that are discussed actually makes the entire session very interesting and most practical. I think over the years that I have seen that the quality of this various events that are organized by Dr. Agarwal under the aegis of Mumbai Hematology Group is phenomenal. And I think this is evident by the number of participants. And now I gather that you have participants not only from India, but from many other countries who are listening to these great sessions. And these sessions are really an academic treat. So on behalf of all the hematologists, I really extend my sincere thanks to you, sir, for organizing these events meticulously and with the same degree of passion over the years. So sincere thanks to you and hats off to you for doing these for years now. And I think with these words, I'll stop here because all of you are awaiting listening to the speakers and the discussion that follows. So wish you a great academic event ahead. And thank you so much once again, sir, for inviting me.
Thank you, Dr. Manisha, for those very, very kind words and also sparing your valuable time to bless us by your kind presence and inaugurating the day 6 of this Best of ASH. Thank you indeed.
Thank you.
Just share my screen to introduce our first guest speaker. So friends, the first lecture, as was told, is on Posaconazole Delayed Release Tablet for prophylaxis against invasive fungal infections in hemato-oncology. The speaker is Dr. Biju George, Professor, Department of Clinical Hematology at Christian Medical College, Vellore. You all know him. I have to complete the formalities. He was Clinical Fellow at Westmed Hospital, Sydney, Australia. At CMC Vellore, he also served as lecturer, followed by assistant professor, followed by associate professor in hematology between 2002 and 2007, before becoming professor. He has a keen interest in academics and research. He has authored or co-authored over 170 publications. is frequently invited as a speaker at various national and international meetings. Is a reviewer of papers submitted to eminent hematology and medical journals. Is an extremely active member of Indian Society of Hematology and Blood Transfusion, American Society of Hematology, American Society of Bone Marrow Transplantation, Asia Pacific Bone Marrow Transplantation, and International Society for Cellular Therapy. This lecture is supported by MSD. Thank you so much. And now it's all over to Dr. Biju George.
I'm just sharing my screen. Is my screen seen?
Yes.
Yeah. Thank you very much, sir, for that introduction. What I would like to do over the next 30 minutes is to look at the role of tablet posaconazole in patients undergoing chemotherapy and so developing neutropenia, or those who undergo a stem cell transplant. So we need to always remember that in hematology practice, majority of the patients who have severe neutropenia where the ANC drops below 500 do develop fever. Bacterial etiology is probably seen in about 10 to 20%, and cultures are positive, but majority of them are culture negative. 30 to 40% have what we call as fever of unknown origin, but 30% have fungal infections. Now, this can occur in the setting of chemotherapy-related neutropenia, transplant-related neutropenia, or when you have potent immunosuppression because of treatment of graft versus host disease. And if you look at various data, both in adults and pediatric, patients with AML, ALL, and allogenic transplant seem to be the three major groups where you have a high incidence of invasive fungal infection. This is data from the pediatric setting where again acute graft versus host disease, high-risk ALL, relapsed ALL, AML seem to be the important groups where you have a high risk of fungal infection. Now, when we look at fungal infection as a whole, you have a patient who starts with transplant or chemotherapy, then develops fever, pleuritic pain, or non-specific signs. Here we say patient has probably got possible fungal infection. Then you may use either galactomannan or other serological tests to actually help establish the diagnosis. We call it probable. And if you have a biopsy proven disease, then you call it as a definite or proven fungal infection. Now, this is bad because there is a 40% mortality even now associated once you develop proven fungal disease. So what you're trying to do is work somewhere along this way with antifungal drugs to try and prevent the state of proven fungal infection from occurring. So you could start antifungal therapy as soon as you start your chemotherapy or transplant. This is prophylaxis. You could start antifungal drugs when you have just fever, which is not responding to antibacterial therapy, and that is called as empirical therapy. You could do what is called as preemptive or diagnostic driven, that is, you have some telltale signs on X-ray, you have galactomannan positive, and then you start antifungal drugs. But what I'm going to talk about now is prophylaxis. And I'm sure all of you are aware there were two large trials, both published in NEGM in 2007, one on graft versus host disease and one on MDS AML, which compared posaconazole with what was considered standard of therapy at that point of time, fluconazole or itraconazole, to look at the role of posaconazole prophylaxis. Now, this was a suspension given at 200 milligrams 3 times a day. And this was the primary data from the in the neutropenic patients. Essentially, they showed that posaconazole was superior to fluconazole or itraconazole at initial period or through 100 days in reducing the risk of proven both overall IFIs as well as in terms of reducing aspergillosis. And it showed a definite reduction in the mortality from 21% to 14%. So almost a 7% reduction in mortality at day 100 after starting off the drug. Similarly, in graft versus host disease, although there was not a significant difference in the overall invasive fungal infections, there was a definite reduction in the invasive aspergillus incidence, both through 16 weeks as well as initially after therapy. So at that point of time, posaconazole became A1 recommendations for prophylaxis either during chemotherapy or when the patient developed graft versus host disease. But there were some inherent problems with syrup posaconazole. One is it's a syrup, the absorption varied widely, and not all achieved therapeutic levels. The recommendation was to actually eat it with a fatty meal with butter or with Coke, and that was not always possible. Remember, somebody who's on day 10 post chemotherapy after AML with severe mucositis, mouthful of ulcers, it's difficult to persuade them to eat anything at all. Forget about them having to eat with butter or a fatty meal. The other important thing was that in patients who were in the GVHD study, they excluded those who had more than a liter or a liter and a half of diarrhea per day. So we did not know when we looked at grade 3 or 4 graft versus host disease, whether the syrup posaconazole was useful, and you cannot use proton pump inhibitors along with this drug. So the question was, can we do better? And that is where the posaconazole tablet has come into being. These are 100 milligram delayed release tablets, which are active against multiple pathogens, including Aspergillus, Mucor, Rhizopus. And these tablets are not extensively metabolized. There are no circulating metabolites. Most of it remains unexchanged and eliminated in the feces, and it's not renally excreted. Now, there is a delayed release in the stomach, which means that the posaconazole actually reaches the small intestine. The advantage being that because it is released in the small intestine, proton pump inhibitors, antacids do not interfere in the stomach when we come to the use of the drug. It is usually given as a dose of 300 milligrams BD on the first day, followed by 300 milligrams once a day. You have to swallow the tablets whole without dividing, crushing, or chewing, and you can use it with food to enhance the oral absorption. Now, how did it get approved? One of the important things to remember is that most of the studies which I'm going to shows the metabolism and the absorption and the levels of tablet posaconazole rather than efficacy. Now, the understanding of the FDA was that syrup posaconazole has already been shown to have clinical efficacy in specific scenarios: AML, MDS chemotherapy, and transplant GVHD. So if the tablet could show better absorption, pharmacokinetics, and levels in the same group of patients, then that was adequate. You didn't need to have a second clinical trial to look at efficacy with the tablet. So most of the data that I have, which I'm going to present, is basically looking at pharmacokinetics, pharmacodynamics, absorption, and interactions of the posaconazole drug. So the market authorization was based upon pharmacokinetic properties, safety, and tolerability of posaconazole in a similar patient population that was studied in the pivotal posaconazole oral suspension clinical program. And this helped in bridging the pharmacokinetic and the safety of the posaconazole tablet with the oral suspension. Now, what did it show? And I'll come to that. Basically, 81% had a level above 500, between 500 to 2,500, with the use of tablet posaconazole with an average plasma concentration of 1,970. Now, the worry about Breakthrough fungal infection usually occurs when your posaconazole levels are less than 500 nanogram per mil. And so 81% actually got between 500 to 2500, and about 18 to 19% actually went above that. So the question is whether this group has more toxicity than what we saw with syrup posaconazole. So the first study was by O'Connelly looking at pharmacokinetics and safety study of posaconazole in patients with invasive fungal disease. This was a global study, open label, multi-center trial of PK and safety. And basically, if you look, the groups are the same. Those with neutropenia undergoing chemotherapy for AML, MDS, and those having therapy for treatment of GVHD. Essentially, they got a loading dose of 300 BD without regard for food on day 1, and samples were collected on day 1, 3, 8, 14, 21, 28, and they studied a total of 210 patients, essentially to look and see what is the steady state posaconazole concentration and what percentage were able to achieve it. So they studied initially about 50 patients and then went out to the 200. And this is the steady state after getting 300 BD. If you look here, the average levels were about 1,580, which was there in about 42%. It was about 1,870 with transplant and 1,440 with AML MDS, which meant that most of them were getting actually a good level with the use of posaconazole tablets. Now, if you sort of split it by in terms of what they had, you see here just about 4% and 6% actually had levels less than 700. So which means that majority had levels which were good. So this is 86% and another 10% had between 2,500 to 3,700. And in both, individual variability is there, but if you look here, the levels of about 1,500 were achieved both in the transplant arm as well as in the AML arm. Now, when they went forward and looked at the entire group of those who had got multiple doses subsequently, the median levels were sitting at about 1,700. It was higher in the group who had had a transplant as compared to those who had AML. And I'll come to that subsequently. That is because of interaction with other drugs which are used during the transplant process. But essentially, like I mentioned previously, more than 80 to 90% actually got levels above 700, which means it is safe enough to try and prevent fungal infection from occurring in this group of patients. And so this is the breakdown for the entire group. If you look here, there is about 3.5% who had less than 700, while majority had above 700, with about 80% having between this group of 700 to 2,500. Treatment-associated adverse events were there in about 40%, serious adverse events in about 38%, deaths in 10%. But we need to remember when we look at SAEs and deaths, these are not related to posaconazole, but they are more related to the kind of disease that we were treating with, which are all captured as serious adverse events. Now, study discontinuation due to an adverse event was seen in only about 18%, while in majority of the other studies, we are looking at 30 to 40% discontinuation because of an adverse event. Now, what were some of the adverse events? There were mainly diarrhea and nausea and mild abdominal pain. That these were the only two which were the higher, about 8 to 10%, and the rest were all much lower. Importantly, liver function abnormalities were seen in about 2% and 4% of ALT/AST abnormality. So the conclusion of that study was that 300 milligrams taken once daily had a tolerability similar to oral suspension given to the responsive representative formulation, and when taken, majority got above 500 to 700 in this group of patients. There was also a second study looking at this tablet in patients with neutropenia, looking at two cohorts, one which got BD and then looking at them going towards 28 days looking at a primary parameter on average at day 8. So we need to remember that it's not just the levels that you get on day 1 which determines whether you're going to get fungal infection, but whether you're able to sustain these levels during the period when you expect neutropenia to occur, and whether that levels will also help influence who are likely to get fungal infection. And the hypothesis was that with the use of tablet posaconazole, at least 90% of patients will maintain a level more than 500 at steady state, which means on day 8, and that will help in reducing the risk of fungal infection. So there were 2 cohorts. One was a cohort which got 200 milligrams. One was a cohort which got 300 milligrams, essentially to see which is the one which is better in terms of preventing fungal infections. And they looked at the patients were studied till a survival on day 50, but they took multiple samples over a period of time. So this is the 200 and 300 cohorts. Essentially, there were no difference in terms of age, sex, race, and the weight and height. And what we found was that the average AUC or the C max, which is the maximum levels, were definitely higher in a 300 as compared to 200 after you've given the first 24 hours of drug. That is 2 doses. You would expect to have a higher level with 300 as compared to 200 milligrams. But when we followed up this patient and then looked at what happened down the line, even at 24 hours, in the 300, which is maintained by the black, you continue to maintain a level close to 1000 at 24 hours. It was lower at about 500 in the 200 milligram arm. Now, when we looked at day 8 after giving that BD dosing on first day, followed by once a day dosing after that, what we found was in the 200, you got about 1270, and in the 300 milligrams, you got about 1960 milligrams that was maintained over a period of time. And so on day 8, this was the kind of level. So it was a much higher level that you achieved with once a day dosing of 300 as compared to this, which was basically once a day dosing of 200 milligrams. So you got better levels, but even the 200 did achieve levels as compared to the 300. Treatment-related adverse events, which consisted of serious adverse events, were seen in about 24 and 30% with both the 200 and the 300 milligrams, and roughly about 15 to 20% had adverse events which led to the study drug discontinuation, and which were mainly gastrointestinal study drugs. So essentially what the conclusion was that the new formulation taken at 300 milligrams achieved the pre-specified PK exposure target, that is a level of more than 500 and less than 2500 in more than 90% of patients. Importantly, they achieved this level within 24 hours. Most of them were well tolerated, and the safety profile was similar to what happened with posaconazole oral suspension. Now, this is a comparison between the data from the oral tablet versus the previous data that was available from the syrup, 2-3 trials of syrup posaconazole. And essentially, when you look at different quartiles, the ranges which you see in each of the quartiles is definitely far higher with the oral posaconazole as compared to the syrup formulations in any of these 3 studies. So definitely the oral posaconazole was associated with much higher and better levels of the drug when we given it orally as compared to the syrup posaconazole. So the next question was, now we have shown that it is good. Are there concomitant medicines which affect the gastrointestinal motility and pH that can affect the tablet pharmacokinetics? So this was a study which basically looked at posaconazole either alone or in combination with other drugs in healthy volunteers. So either they got different treatment periods, which is basically they got posaconazole tablet alone, or posaconazole tablet with an antacid, posaconazole tablet with ranitidine, posaconazole tablet with esomeprazole, and posaconazole tablet with metoclopramide. There were actually 5 different arms. What happened was they started with one arm, and then there was a washout period. They went to a second arm, washout period, the third, fourth, and fifth. So each time they got posaconazole either alone or with one concomitant drug. And essentially, they looked to see in a group of healthy volunteers, did any of them affect the posaconazole pharmacokinetics? And what they clearly showed was that this is posaconazole alone in terms of the levels. This as compared to the use of any of the other drugs, whether it be antacids, ranitidine, esomeprazole, or metoclopramide, they did not interfere, and you managed to achieve very good levels with the addition of any of these drugs along with posaconazole. And this is what was in terms of looking at the delayed release tablet and looking at the levels after you've taken the tablet. So if you look here, this blue is posaconazole alone, the rest are all with some tablet, and all of them actually the lines sort of merge and you're not able to separate them out. This means that whether you give posaconazole alone or you add some other drug to the posaconazole, there was no difference as compared to the posaconazole alone. And when we looked at the geometric mean ratio of posaconazole as compared to the other drugs, there was no difference, which suggested that these drugs did not actually interfere in the posaconazole levels. So the conclusion was that posaconazole may be co-administered with gastric agents, antacids, ranitidine, esomeprazole, or metoclopramide without any clinical important reduction in bioavailability. The question is special populations. Is there a difference? So this is data on renal insufficiency showing that even in severe renal insufficiency, there is no effect on the pharmacokinetics. So you don't need to make any dose adjustment in renal impairment. The second is on hepatic insufficiency. So the data seems to suggest that whether you are child-puke mild, moderate, or severe, the pharmacokinetics is similar. And so the existing data suggests that there is no dose adjustment that is needed of posaconazole even in severe hepatic insufficiency. When we come to pregnancy and lactation, we have to remember there is not enough data. And so they believe that you have to sort of weigh the benefits versus the risk if you want to use it in a pregnant woman. Similarly, in terms of nursing, we are not clear in terms of the amount of excretion that occurs in human breast milk. And so the clinician has to make a decision on whether you want to offer it to a nursing mother or not. Now, most of the pharmacokinetic modeling that has been occurred is for a weight less than 120 kilos. So when we go up to 300 OD, that is all right for 120. Once you go on weights above that, you have to closely monitor. Best would be if you can do levels and see whether you're achieving adequate levels, especially when you go above the weight of 120 kilos. Now, when we look at children, there are some small studies to suggest that above the age of 8 years, they achieve concentrations similar to what adults would achieve. So there is data from 8 to 17 and from 13 to 17 suggesting that they all achieve above 700 milligrams. But there is no data for less than 8 years of age. There is no gender difference between males and females which compared to posaconazole. There is no dose adjustment needed for older patients who are above 65. And this is important when we look at older patients with AML and MDS, where we are putting on, say, azacitidine or azacitidine with venetoclax, and there we are giving posaconazole as prophylaxis to prevent fungal infection. There is also dose adjustment for race that is required. So if you look at what were the inherent problems with posaconazole and what is happening with tablet. Now, the first inherent problem was the absorption varied. Not all achieved therapeutic levels. There's data to suggest that between 30 to 60% only of syrup posaconazole would actually achieve the levels. But here we know that more than 90% achieved therapeutic levels in multiple studies. Eating with a fatty meal butter was not always possible. And here it's not required to have a fatty meal. Food is not a factor that is required for absorption. Grade 3 to 4 GVHD patients are not included in the GVHD study. There is data to suggest that the absorption may not be affected by diarrhea. Cannot use proton pump inhibitors along with syrup posaconazole. Here there is data to suggest that proton pump inhibitors, antacids can be used along with tablet posaconazole. Now we need to always remember that none of these are totally safe in the sense that there are drug interactions which we have to keep at the back of our mind. So we need to remember that drugs like rifapentine, efavirenz, phenytoin can all decrease the posaconazole levels. CYP3A4 substrates such as terfenadine, cisapride, ergot alkaloids can increase. So do HMG-CoA reductase inhibitors. Now, it is not that you cannot use them, but if you do have to use these drugs along with posaconazole, you need to monitor the levels so as to prevent toxicity from occurring. Similarly, some of the drugs used in chemotherapy or transplant, cyclosporin, sirolimus, tacrolimus, all can, the levels can be increased with the use of posaconazole, and so you need to monitor, which is what we do. HIV protease inhibitors, benzodiazepines, again, their levels would increase. You have to be worried if you're using concomitantly digoxin and posaconazole because dig toxicity may increase. So these are not contraindications which are absolute, but it is just that because these interactions are present, you need to keep at the back of your mind and make appropriate adjustments or monitoring to prevent toxicity. So what are the indications for the use of posaconazole delayed release tablets in India? So it's indicated for the prophylaxis of invasive aspergillus and candida infections in patients who are at high risk of developing this. That is, includes patients who've had a transplant with graft versus host disease and those with hematological malignancies. Now we need to remember that the more recent indication is for the use of it in mucormycosis, especially for those who are refractory or intolerant to other therapy. And remember, as of now, the data is to use it in patients who are more than 13 years of age. We need to always worry and remember that there are certain drugs where we have a problem. And so in conclusion, tablet posaconazole is a very good viable alternative. Absorption more linear and more than 90% achieve therapeutic levels. Specific diet is not required, not affected by proton pump inhibitors. And in terms of efficacy, it is as good as the syrup formulation. So you got a drug now which is clinically efficient, as well as the pharmacokinetic data seem to support that you achieve very good levels. This is some of the prescribing data on Noxafil. Thank you for your attention, and I'll be happy to take questions if there are any. Thank you, sir.
Thank you, Dr. Biju George, for that lovely talk and explaining us everything about tablet and its advantage over syrup. Beautiful. So till the raise hand signs come up, I will put some questions from the audience. Dr. Narayanan Subramaniam wants to know that you have Noxafil and we have a lot of generics. Is there any study from India to know whether generics are as good as Noxafil with respect to TDM?
So I should say there are no studies, but we are actually doing a study with the Glenmark posaconazole to look at the levels. We are still in the process of doing the study, so unfortunately I cannot give out the data, but my plea to all generics is please generate data. That is the only way you can get confidence.
Thank you. The second question from him is, what is you must be using now posaconazole tablet or any other form. So what is the breakthrough fungal infection rate in your series?
So we are seeing about 5 to 10%. Now we need to clearly understand, unlike the data that you see from the West, the burden of disease in India is far higher. So previously, when we used syrup posaconazole in patients with AML, MDS, and transplant, our breakthrough rates were in the region of 12 to 13%. Even now, we are seeing about 10%.
And was this related with low drug level or other causes?
These are not, I think these are other causes. I mean, we were just discussing today in the department that for the last 6 months, we are actually seeing an alarming rate of rise in fungal infections, and a lot of it with either sinus and pulmonary and brain. Now, whether this whole thing is pushed by COVID, I don't know. We are doing a study, but these are all people who have more than 700 levels in terms of posaconazole. So the breakthrough is occurring due to other factors.
Thank you. Voriconazole is the standard of care for aspergillosis for its treatment. Do you feel that posaconazole can replace it because of its better adverse effect profile, number one? And number two, often you do not know what's the type of infection, especially between aspergillosis and zygomatosis. In that situation, do you feel there is an advantage of using posaconazole because it may be equally good for both the infections while voriconazole fails in zygoma?
So we need to remember that the data is all on prophylaxis. I know there is a trial going on treatment. So till the trial comes out, the treatment of proven invasive aspergillosis is still voriconazole. The prophylaxis, yes, I think it's got a much better broad spectrum prophylactic cover, and so it may be useful. But till we have data, we cannot replace it with posaconazole cannot replace voriconazole as treatment.
Just recently, there's one study published of about 300 patients of invasive aspergillus infection, where they showed it to be as good as voriconazole. My next question to you is, have you used, the questions may not be related to tablet alone. Have you used it intravenous formulation from peripheral vein? Is it possible, or it has to be central?
I would not be able to answer it because all our patients have got central lines because of intensive chemotherapy or transplant. So whenever we have used it through a central venous axis.
Dr. Prashanta, your question.
Yeah. Good evening, sir.
Hi.
Hi, sir. Sir, my question is regarding the ALL. You know, when you use antifungal prophylaxis in ALL, how do you manage, sir? Because there is a huge interaction between vincristine and these azoles that coming in.
Correct. So two things. One, in primary ALL, we do not use antifungal prophylaxis because our rates of fungal infection are much lower compared to AML. There are a lot of people who use it. The recommendation is that 24 hours before and after the dose of vincristine, you should actually stop azoles if you're using it. We find more fungal infection in the intensive chemotherapy. So if you're using hyper-CVAD, if you're using your relapse protocols, that is where we may find more. There you have to, if you have vincristine as a part of your protocol, you may need to give at least a 24-hour gap between the azole and the dose of vincristine.
So in the upfront treatment of ALL, it is not medico-legally, it is not wrong if we don't give antifungal prophylaxis.
No, it is not medico-legally wrong. If you look at the pediatric data also, it is all in those who have ALL high risk, who are getting intensive chemotherapy or relapsed ALL, not in primary ALL, but it differs from institution to institution. I know the All India Institute have described a higher incidence of fungal infections among the children with ALL. We don't see that, so we don't use antifungal.
Thank you.
So Prashanta, either you may not use it, and if you want, you can use it candies. If you have to.
Yes, sir.
Use it. Yeah. They are not useless for aspergillosis. They work. Okay. Dr. Priyanka Agarwal.
Good evening, sir. It was a very nice talk. I
Thank
just
you.
wanted to know, because I'm a pediatric hematologist and oncologist. So what is your experience with posaconazole in children, both prophylaxis and treatment?
So I should say that previously we have used syrup posaconazole in children. It was at a different dose. We were using at a 5 milligram per kg dose, which is what was data that was available. And what we found was that the levels we were getting were adequate. Okay. The tablet posaconazole is common. We are just using it in adults because that is what is recognized by the DCGI in India. So our study is mainly on adults, but there are 2-3 children where those who develop GVHD where we have used it, and there we are finding that we are getting adequate levels.
Okay, sir. Thank you.
Dr. Ritika.
Good evening, sir. Thank you for a lovely talk. So I'm a pediatric hemato-oncologist practicing in Mumbai. So we see fungal infections often. We have a couple of patients with CNS invasive fungal infections also, both aspergillus and mucormycosis. So sir, how is the CNS penetration of oral tablet form of posaconazole versus the syrup form? And
so I may be biased, but to be CNS aspergillosis, I always prefer to shift to isavuconazole because that seems to have the best penetration. But I would qualify it by saying that I don't think there is much data on the use of isavuconazole in children. And so you have to be a little bit careful about that. We generally use a combination of amphotericin with Mori seems to have reasonable absorption and penetration, although isavu is better.
okay.
So I would use a combination. And I think more importantly, when we see this, ones who have brain, what we try to do is at least 2 weeks, we try to do a limited imaging just to make sure that the lesions that are there are at least stable, if not coming down. That will give us a hold in terms of whether we are actually dealing adequately with the fungal infections.
Right, sir. Thank you.
Thank you. Dr. Arihant Jain wants to know whether there is a drug interaction between azoles and midostaurin.
How? I have to check that. I'm not sure about it. I have to check that, sir. I'm not clear about whether we can use it. So you should tell me, sir.
No, okay. So there is drug interaction, but it is of no clinical consequence. So the pundits in AML field have said you don't have to bother about it. You can continue posaconazole and give midostaurin. No clinical issues.
Okay.
Yes, pharmacokinetically there are. So I think that's all what we have for you. Any other question from the faculty? Yes, Dr. Satish.
Good evening, sir. Enjoyed your talk. Sir, I wanted to know what prophylaxis at CMC Vellore they're using in elderly AML on hypermethylating agents, sir. Not on...
So we use posaconazole, and that is essentially because we are trying to reduce the dose of venetoclax that we are giving.
Sir, if you're not giving venetoclax, sir?
So even still, when we were using azacitidine or decitabine alone also, we were still using posaconazole prophylaxis. And they continue it till we take them off the hypermethylating agent.
I mean, even after 4 cycles, you continue it, sir?
Yes, we would continue it. Sometimes what happens is by the time we reach the 5th and 6th cycle, if they are in good remission and good neutrophil counts, and we are continuing it as a sort of maintenance without going for transplant or anything, we may take it off that point of time. Okay. I think the most important thing that would dictate is what is your neutrophil count and whether you are neutropenic or not.
Sounds good, sir. Thank you, sir. Dr. Ankit Rayani.
Thank you, sir, for that wonderful lecture. My question is of practical purpose. If the dose is 300 mg, why is the tablet for dose the strength is 100 mg?
So when you looked at the previous data that showed that people looked at, actually initially they looked at 100, 200, 300, and then the dose finding study showed that 200 and 300 may be useful. And then subsequent studies looked at 200 and 300. So I think that is the reason why they decided to put that. And I would say that once you start going to pediatric, it is better to have a smaller, because otherwise you're going to end up breaking up a tablet, which then the whole thing of gastric release and the delayed release goes off. So
Right.
I think that way 100 tablet will be useful once we find the area where you can use it in children.
Right, sir. And one more question is that though you have shown that there is no effect of loose motions, diarrhea on the bioavailability, would you feel comfortable using the Posaconazole tablet in grade 3, 4?
So right now, even for those who have grade 3 or grade 4 gut GVHD, we still use Posaconazole. So we used to never use syrup, but tablet, I use it. And I find that we are getting reasonably good levels. It may not go up to 1,500, but at least they are above 700. And that is adequate.
Right. So, and the last question, on the similar point of view, if the patient is on his Ryle's tube or NJ tube, have you used Posaconazole in that form? Because you was told that it should not be crushed. And if
so
used,
no.
what was the level?
So there, I would prefer to use IV Posaconazole till we are able to take off the NG.
Okay, right.
Thank you. One more reason for having 100 milligram tablet is the 300 milligram tablet will be this big.
But sir, there is one, I think Sun has launched 300 mg, although it has been hooked up by this post-COVID fungal infection, but I think it is available.
No, I mean, some people can swallow, but whenever a tablet is made in a smaller strength than the therapeutically recommended dose, it is invariably because you are not able to condense the amount of powder that you have into a tablet, which can be easily swallowed by an average. Maybe if Indians can swallow, maybe Chinese and the Japanese.
Thank you.
That becomes an issue. So 3 tablets, small size, is easier to swallow than 1 tablet, which is elephantine. So that is a problem. Okay. You know, some of the generics, they want to compete with the Noxafil, and they come out with various kind of formulation that this is the advantage or that is the advantage.
Right, sir.
So actually, this is a comment actually to answer all of Ankit's questions. We've actually done a study of 200 patients monitoring the Posaconazole levels for various indications. And in those, the analysis, I mean, a detailed analysis is yet awaited, but we've seen that patients who had diarrhea, actually, about 20% of those patients, the levels are lower. Subtherapeutic is less than 700. And those patients with mucormycosis who had NJ tubes, and we had to pulverize the tablet and give them, a good number of patients, almost about, roughly about 25% of those patients had poorer levels.
Okay.
Plus, you know, to answer that question, so if you had a lower level, you would want to go up to 400, not 600. That is why the 100 milligram tablet is important.
Right, sir.
Biju, will you recommend that if TDM is not available, not to use azoles?
No, sir. I think the data is consistent that if you use standard or the innovator molecule, you are going to get good levels in more than 90%. My worry is with the generics. I'm not against generics, but unfortunately, the way DCGI approves, they approve without any clinical study, and they just want an equivalence. Then to use it in one of our patients who's sick, I don't get that confidence unless I have levels.
True. In fact, there is a Belgium study saying that you don't need TDM level with Posaconazole because breakthrough infections, if your breakthrough infections remain around 3 to 7%, then you'll be happy. That means you're achieving what is achieved. As TDM levels are not widely available, they may not be reliable and they may take time. So you don't have to bother. I mean, in a country like India, 90% of us will not have an access to TDM. So without bothering about it, we can use it. I think that's it. We won't be able to accommodate more questions. Thank you so much, Dr. Biju.
Sure, sir. Thank you for the invitation, sir.
And thanks to the faculty here for very, very great interactive session. And thanks to MSD for supporting over this part of the webinar. And I'll just share my screen to introduce second speaker. She's already there with us. Okay, so our second lecture today is on ITP. And speaker is none other than Dr. Cindy Neunert. She has been our faculty for years. She was in Mumbai a couple of years ago. She has also been giving webinars in this pandemic era. She's Associate Professor Pediatrics, Section Head Pediatric Hematology, Columbia University Medical Center, New York. She did her fellowship from University of Texas Southwestern Medical Center. She's an expert in benign hematological disorders. Her areas of research and specialization include ITP, hemostasis, thrombosis, and sickle cell disease. She's involved with the Intercontinental Cooperative ITP Study Group, which is an international study group advancing knowledge regarding the natural history of ITP in children and adults. She is author of the ASH 2019 guidelines for ITP. She was past chair of the Pediatric ITP Consortium of North America, which is a group of 40 pediatric centers conducting studies on the biology of ITP, as well as the conduct of patient-related and interventional trials. She now serves as a co-chair for the interventional subcommittee. This part of our webinar is supported by Alkem. I'll stop here and request her to give the talk. Welcome, Dr. Cindy Neunert.
Welcome, welcome. Always a pleasure. It's a cold, snowy morning here in New York City. So I have different climate than you all do right now, for sure. Okay, let me pull up my PowerPoint, go to share and full screen. There we go. Can you all see that?
Yeah.
Good, perfect. So it's always a joy of mine to talk about ITP and particularly to bring updates, as I think that actually the last couple years at ASH, it's been really exciting in that we actually do have some updates. I think there was a time where we were feeling as though there was a paucity of new discovery for patients with ITP. And then we had the explosion of the era of the TPOs and some other new therapies such as fostamatinib, and now we're sort of continuing to expand that with novel development for targeted therapies for ITP, but also a better understanding of immune modulation and immune dysregulation and how to apply some of the other immunosuppressive therapies that we have. So during this, I'll do an overview of kind of our current therapies and discuss abstracts from the 2001 meeting related to these therapies. And that's going to really be the focus, is using the ASH abstracts as the backbone for this. I'll present some data on novel therapies that are under investigation, and then also some clinical trials that are underway that were presented at the meeting. And then I thought no talk in this current era would be complete without some discussion of COVID. And there were a couple abstracts on COVID and ITP from the ASH meeting that I thought would be worthy of including. So this is sort of our understanding of the pathogenesis of ITP. And this is a slide I always like to use because I think it just helps ground us in sort of where we are in the current landscape of our therapies. And we've really understood a lot more, as I said, about this, the production of autoantibodies and the drivers and the cells that are involved. From this became our use of rituximab, which is really targeting our autoreactive B cells. And rituximab still remains on the forefront of therapy. If we look at the ASH 2019 guidelines, rituximab is suggested as a therapy for patients who fail corticosteroids up front. We also have splenectomy as our #1 historical go-to for treatment of patients. And this is really because it just simply targets the place of platelet destruction, with those macrophages in the spleen being responsible for removal of antibody-coated platelets. We do have our SYK inhibitors. The one that has been approved, at least in the US, for use is fostamatinib. And this changes, this interacts with SYK, and I'll get into this a little bit more, but it does not allow the right shape change in the macrophages. And then, as I said, kind of one of the most exciting advances was sort of the recognition of the interplay between these antibodies and megakaryocytes, leading to decreased platelet production, and the development of the use of the TPOs, or stimulators of the megakaryocytes in the bone marrow. I did a previous talk kind of showing advances and where we're going and what else we're using now with regards to the antibody production component. People are exploring BTK inhibitors. We have some FcRn monoclonal antibodies that block recirculation of our IgG antibodies that are directed against the platelet glycoproteins. There's some work being done right now on complement and complement activation, and if complement inhibitors would also be novel therapies that would be useful for ITP. So at the ASH meeting, there were a couple abstracts that actually relate to our current therapies. And if we think historically, I think it's really interesting to see the data that's coming out on splenectomy. I can tell you when we worked on the guidelines, one of the concerns we had was that the only data we had on splenectomy and splenectomy outcomes was really from old cohorts. So cohorts where splenectomy was being done quite early in the course of ITP before we had all these other agents, rituximab and TPOs. And so we really didn't know if outcomes would be different in a more modern cohort. And there was one abstract that addressed this, and this is a multi-center retrospective study of adults undergoing splenectomy between 2011 and 2020. They had 185 patients with a mean follow-up of just about 3 years on the majority of the patients. 81% of the patients had chronic ITP, and only 2 patients underwent splenectomy within 3 months. So that alone is sort of a shift from what I think we would have seen or did see with some of the older cohorts that we were using for the guidelines, where if you failed corticosteroids, you kind of immediately went by default to splenectomy. Also looking at previous treatment, about 50% of the patients had been on a TPO-RA prior to splenectomy, and 73% had received rituximab. And this is in line, again, with sort of what we established in the 2019 guidelines, where really there was a push to delay splenectomy for at least 12 months and suggestion that either TPOs or rituximab be used prior to progressing to splenectomy. In this, about 80% of the patients had an initial response, so not much different than our historical data, with about 65% sustaining that response at last follow-up. So this just shows this table that I liked that shows it by years and by kind of cohorts of years. And you can definitely see that there's a shift to reserving splenectomy for patients with prior therapies and not just as a first or second line immediate therapy. And then also a number of patients receiving either althrombopag or rituximab as outlined down here in this graph, where these numbers sort of slowly increase over time. Perhaps maybe not as great a change for rituximab since this goes back to 2011, but definitely an increase in the number of patients exposed to a TPO prior to splenectomy, and then a greater number of patients experiencing sometimes even 5 or 6 therapies before progressing, and then a decrease, certainly the majority of patients being chronic. So I think this really mirrors what we're seeing. What I do think is nice is that they showed that despite this, there really weren't any changes in the outcomes of splenectomy. So by delaying for a year or by exposing to treatment prior to splenectomy, we really didn't see any change in the outcomes or response rates, which sort of supports what we were looking for as guideline panelists in making that decision about, do we need to take consideration of a modern cohort? So this group of 200 patients, or close to 200 patients, really helped us with that a little bit, feeling a little bit more comfortable. So hopefully there's also a registry that the Intercontinental Group did in pediatric patients that I know has just closed to enrollment. It took quite some time to get pediatric patients enrolled because we do so few splenectomies, but we should have relatively up-to-date information from that registry shortly as well for pediatric patients in splenectomy. They did also in this paper look at a lack of sustained response after splenectomy. It was related to older age, and then perhaps if you had more than 4 lines of treatment before your splenectomy. So the very, very heavily treated patients. And I will say, oftentimes I see patients in a second opinion, and they are the patients that have failed 4 or 5 medical therapies. And I'm very reluctant to do a splenectomy on them in the sense that there's just something about their ITP that seems very different particularly in a child, splenectomy being such a permanent procedure, I tend to shy away if they've failed multiple other therapies. Just out of my own kind of anecdotal, those patients tend to not respond to splenectomy either. So there was a little bit of data on rituximab. So even though it's been out for a while, there was one nice study out of the UK registry data. The UK registry is really an amazing source of information and really well organized, and they are to be commended for the work that they've done. They looked at both rituximab and mycophenolate mofetil to look at outcomes in a real world setting. And they had 486 rituximab patients and 358 MMF patients. So as I said, a commendable number of patients to have enrolled on ITP studies. And what they looked at was, again, because this was just a registry, they did have some dropout and follow-up, but they looked at patients at week 4, week 12, month 6, month 12, and 2 years. And these are patients just getting started on rituximab and MMF, either with or without other drugs on board, and really at the discretion of the treating provider. So some patients might have even had a higher platelet count when they started, but they were getting these treatments to transition off of whatever they were currently on. But what you can see here is with rituximab, there was about a 40% response rate, either partial or complete by week 4. That got up to about 50% by week 12, and then was back down, drifting to 40, 30, and then as low as 20% by 2 years. MMF was pretty consistent at 30 to 40% of patients showing a response. And then at 2 years, again, similar to rituximab, about a 20% response rate. What I could not gather from this abstract, and that will hopefully be in the main paper, is what the procedure was with handling MMF. So how many of these patients came off MMF, and what do these platelet counts represent? So there's a little bit of a devil in the details that's not available when you're just working off of an abstract. This does show the same data, but looking at those patients that had a platelet count less than 30,000 at baseline. Here they presented data just at the 4-week, the 12-month, and the 1 year. And what you can see is about 40 to 50%, and then 30, and then 30, 30, and 18 in terms of our responses. The median duration of response was 44 weeks for rituximab and 27 weeks for MMF. When I was saying it's hard to tell who came on and off therapy with MMF and what that represents, what we do know is that a change in treatment during the follow-up period, which again was variable for each patient, was seen in 77% of rituximab patients and 80% of MMF patients. So eventually the majority of patients required some transition to another therapy. We don't specifically know also the reasons for those changes, if it was due to a personal preference, if it was due to lack of response or loss of response. And then over half the patients also received some amount of rescue medication during the follow-up time period. What I think this does show us is, again, this mirrors kind of our historical data. So when we always take kind of trial data, we want to mirror it with real world studies. And in the previous studies, adult and pediatric, about 60% of patients had an initial response rate or some degree of sustained remission. But then that dropped to as low as 30 to 40% at a year and as low as 20% by 5 years. And so I really think this highlights that rituximab can get us a nice window of patients being in remission, but it may not offer the durable remission, and patients still require quite a bit of following after receiving rituximab. And then it looks like the same is true for MMF. And again, MMF requires ongoing therapy to maintain a response, so slightly different than rituximab. But I'm really looking forward to the full publication on this abstract, because I feel like there's a lot we don't know about how to position even drugs that we've been using for quite some time to treat ITP, rituximab being one of them. I can say, when we worked on guidelines, we thought about, if there is something out there that can buy somebody some time with a drug-free remission, is that good enough? Even if we know that within a year they might have to switch to another therapy. And when you talk to patients, I think this is where this sort of individualized treatment approach comes into play, because I've found that there are a group of patients, for me, it's mostly my teenagers, that can very clearly vocalize that they would rather have a therapy that is a very short duration and then allows them to live drug-free, even if they recognize that that might not put them into a lasting remission for several years. Just even having a window of time of not being on drug therapy, but being in remission is really an ideal goal for them. So I think some of this also comes down to how we talk and communicate with our patients and the importance of that. So we are still learning about the TPORAs. I think the story is not done with them. We're still having lots of ongoing data come out. So as we all know, there's 3 available. There's Remipilstim, L-thrombopag, and avathrombopag. Remipilstim is our sub-Q weekly drug. L-thrombopag and avathrombopag are oral daily medications. The main difference of these drugs is not just only that route of administration, but also with L-thrombopag, we do have to worry about liver toxicity. And then there are dietary restrictions that make it a little bit difficult for some patients. Avathrombopag kind of came on the market to alleviate that, in that it does not require liver monitoring and does not have the same dietary interactions. We are really happy now that we have L-thrombopag for pediatric patients. We've always had Remipilstim for pediatric patients. Avathrombopag is currently only dosed and advised for adults. With all 3 of these, the thought was that discontinuation resulted in thrombocytopenia. So the minute a patient stops taking these drugs, the platelet count can decline, sometimes even lower than what they were at baseline, and patients can experience bleeding. Reports suggest no cross resistance, and there was actually one abstract that I'll share with you that sort of highlights this. And then all of them across the board through numerous studies, it could be a talk on its own, have been shown to increase the platelet count, decrease bleeding, reduce the need for additional medications, and to some degree improve quality of life, although I think that's still a huge area where we could do a lot more work. Is really showing what the impact of these medicines are on the patients, not just on their blood results. And then again, this notion of sustained remission following use, and this came up in one abstract as well. And the thought here is that perhaps there's some degree of immune tolerance. So when you take a system and you expose it repeatedly to high doses of that antigen, do we just burn out the system? And maybe that's what the TPORAs are doing, similar to when we expose patients with hemophilia to high doses of factor. And that's been shown that these patients that seem to have this remission, and we call it remission, it's more a drug-free remission because it's not platelet counts of 150, but it's a sustained response. More so than a remission, because usually they look at platelet counts being above 30 to 50,000 after treatment. These patients also show changes in the T and B regulatory cell compartments. So something has occurred that has caused a shift in the immune system. And it's hard to know if this is truly drug related or if this is something that is more the natural history in that cohort of patients. But I think it's an interesting concept when we think about what we know about immunology and antigenic stimulation and immune tolerance. It's also been shown that some patients that don't respond to a TPO on their own, if you add in just a low background of, say, very, very small amounts of corticosteroids or MMF, or even some people have done sirolimus, that seems to kick in. So that combination, that synergy is also there, which would again support that maybe there is some degree of immune modulation occurring. So this was a nice kind of study that came out of the Boston group. And for each of these, I've put the abstract down at the bottom just for your reference in case you want to look these up for further details. But this was a study in 44 patients. So while a small group, what they were looking at is switching from Remipilstim and L-thrombopag to avathrombopag, which is the newer agent. And what they were able to see is that many switched for convenience, which isn't surprising when you think about some of either a weekly injection or dietary concerns. But I liked this group here, and this was the group that was most interesting to me. So this was a group that switched because of lack of efficacy. So these were patients that were not responding to Remipilstim or Elthrombopag. And if you look here, almost 70% of them just had some response, whether with or without rescue therapy, to Avathrombopag. And that is a good story to me, because I have some patients, in fact, I just saw a teenager the other day who started having a response to Elthrombopag, and it really has declined over time. We were discussing what treatment options were available for her. And I said, I really actually think Avathrombopag might be an option, and or Remipilstim, depending upon which fits your lifestyle better. And in part because after talking to her, what was really occurring was that it was really hard to keep up with a lot of the dietary workaround of Elthrombopag. We also talked about how taking a daily pill was a lot for her now that she's in college, and how Remipilstim may also be a better option down the road if we could get her to be able to administer herself. So I don't know if that's part of this lack of efficacy, if it really isn't a lack of efficacy, but just a lot of issues around adherence. And I think it's good for us to always talk to our patients and figure out if they're not responding, what the barriers might be, and what options might help work around that. So I think that's really good. And 74% of the patients continued on this drug and did really well, and was maintained about 89% of the study visit times. So again, I think we shouldn't throw out all TPOs if a patient doesn't respond to just one of them. It's worth recircling back and considering them as individual drugs, not just as one class, and saying, well, you failed a TPO and we should move on. There's a little bit of data coming out about Avathrombopag and thrombosis. This is obviously a side effect that we worry about with the TPO-RAs. This was a study in 130 patients that were from across 4 of the Avathrombopag clinical trials. And the total thromboembolic events was 7%. The platelet count at the time of event ranged anywhere from 19,000 to 571,571,000. With only 2 patients really being above 450. And there were no dose adjustments within 3 weeks of the event. The patients were on a dose anywhere from 10 to 40 milligrams. And the events ranged from study day 8 to as far out as study day 335. This abstract really just shows very comparable results between Avathrombopag and Remipilstim and Elthrombopag, in the sense that these really, I still don't know if we know that these are truly related to the drugs themselves, or if these are other characteristics. We know that patients with ITP alone are at risk for thromboembolic events. I think it also shows us that over time, there doesn't appear to be an increased risk, and that these events can happen at any point. It is something we need to counsel patients on and think about if we're choosing these agents, thinking carefully about their other comorbidities or risk factors for thrombosis. I do think it's interesting that across all 3 drugs, none have shown that the thromboembolic events are related to that spike in platelet count, which is what I think everybody's worried about, and why all of the dosing parameters say to decrease if the platelet count goes over 450. We sort of use that as an indicator to hold the drug and dose adjust, but it really does not appear that that is a contributory factor to this. This is some data on Elthrombopag out of the RISA trial, which is a trial out of Germany. It's a non-interventional trial that's being conducted. They had 261 patients that have been followed on Elthrombopag. And if we look at a platelet count over 50,000, that happened at least around 80% of the time to 90% of the time, depending upon when we were looking. They did show a reduction in bleeding events compared to baseline. So baseline rates are about 1.4. That was reduced to 0.6 after 1 year of use, and as low as 1.3 by 2 years of use. And then what I liked about this trial is this trial did include some results on fatigue, and they used the FACIT F score, which is a valid instrument for assessing fatigue. And I think this is really important when you talk to patients with ITP. The fatigue component is really important to them. And I think it's important for us to start to look at it in clinical trials. They did show that scores improved from a baseline score of 37 up to a score of 42.5 at 2 years. And this wasn't statistically significant, but it does meet a clinically meaningful difference. So some evidence that in addition to having an effect on the platelet count number, patients are gaining back some quality of life. I think the issue surrounding fatigue, there was not anything new this year at ASH, but it is really a focus of why does the fatigue occur? It's obviously likely multifactorial. We looked at this in our study looking at second-line agents in children, and we were really unable to find clear patterns as to which drugs seem to have an impact, probably because of low numbers of patients enrolled. But even sometimes having a response to therapy with the platelet count doesn't seem to alleviate the fatigue that patients experience. So it's an interesting component of the disease and certainly an outcome that I'm happy to see included in clinical trials alongside other patient-related outcomes. And I also really appreciate the report on bleeding in a meaningful way, not just number of events or percentage, but really using it as an incidence to show a reduction. This was a study that Adrian Newland did that was a subgroup analysis from a phase 2 trial of early use of romipilstim. So what they did was they looked at the 75 patients that were either newly diagnosed or had persistent ITP. So looking at TPO use beyond the kind of label indication, which is for chronic ITP. And they found very good durable and sustained response rates in newly diagnosed patients, 50 and 70%. Persistent was roughly the same, about 50%, and then 90% had sustained. And the difference is just when they checked. The durable was during the first 12 weeks, looking at the last 6 of 8, and then sustained was at any point during the study. They had consistent platelet counts above the criteria for 9 weeks. So a little bit easier to achieve the target for sustained, which is why those numbers are slightly higher. And I think all of us that have experience with the TPOs know that there are patients that sort of roller coaster with them. And we've learned to tolerate ups and downs and dips, and every patient seems to almost have an individualized treatment plan, because if you follow the strict dosing nomogram, you might make yourself crazy with an individual patient that's very sensitive and tends to have their ups and downs. They did look at treatment-free remission following use, and in newly diagnosed patients, this was 40%, and in persistent, this was 20%. And this sort of semi-supports maybe earlier use of the TPOs. And we don't know, and you know what this seems to suggest, although not in statistically relevant manner, but is there some evidence that this immune modulation is going to kick in earlier? And there have been in the past people that have tried to add TPOs to upfront therapy. There was one trial that looked at that in combination with dexamethasone. We are doing a pediatric study of upfront L-thrombopag. There was one very small study presented, I did not include it in the slides at ASH, on romipilstim use in pediatrics, showing remission following use in newly diagnosed. What I don't think we know, particularly it's hard in pediatrics where so many children are going to get better, we really need to show biology. We need to show plausibility that it was the drug that led to that remission, not just the natural course of the disease. So for our larger multi-center study through ICON using L-thrombopag upfront, we are also doing biology correlates. And I suspect they do have biology correlates for all of these adult trials, and are trying to look at what the picture looks like in these patients that have this kind of treatment-free remission, where coming off drug, they're able to maintain a platelet count of 30 to 50,000, whereas before they were not. And perhaps in newly diagnosed, you know, in adults, to go into a treatment-free remission of 40% is, you know, 60 to 80% are going to fail just with corticosteroids. So to move that dial even a little bit and get a little bit more treatment-free remission with drugs with relatively low side effect may be ideal. Ultimately, I think if you talk to adult patients, what they'd really love to move away from is even ever having to go on a long course of corticosteroids, but I certainly don't think we're there yet. This is the STOP-GO. It's a French study, again, in about 50 patients looking at TPO discontinuation. So this study looked at any patient that had received 3 months of a TPO-RA and had a platelet count greater than 100,000 for 2 months. So once they had a stable platelet count, they began to taper off treatment. They were tapered off over the course of about 10 weeks. And what they showed was that 56% had an overall response by 24 weeks. 50% still had an overall response at 52 weeks, but there were no predictors for which of those 50%. So we're not talking very large numbers, but there is some evidence, and here's our survival curves over here showing relapses. But there is a story here. I think we don't fully understand it. I think we have to be careful because, one, we don't have historical data to compare it to as to who would have gotten better without drug. I think we have to be careful in the sense that we're always working with a population of patients that already responded to the drug. So we have to go back to who was initially included in the studies, because we're really paring down to a very select, pre-selected group of patients by the time we get to these studies looking at remission. But I think it's an interesting story, and one that I look forward to seeing how it unfolds, because if we can start to show a degree of immune modulation without having to suffer the side effects of immune suppression, that's really a nice story for our patients. This last TPO, I really think it's important to come back to the issue of pregnancy. How do we support our pregnant women? Right now, we have really limited options. And so this was pregnancy outcome data from 25 countries. There were 200 patients, and there were 56% of the patients that had an abnormal, but if we look here, this is the normal pregnancy and abnormal pregnancies, the total cases. This is during the first trimester. This is during the second trimester. This is during the third. But half of these, almost 60% of these abnormals were because the infant was born with a low platelet count with thrombocytopenia, which is to be expected in women with ITP. So if we really look, these are probably cut in half. And then of those, a lot of them were also not felt to be drug related, but were due to other pregnancy complications. And the degree to which there were complications was not associated with any timing of exposure. So it didn't appear that the abnormal rates were higher if exposure occurred during first, second, or third trimester. So this abstract, the conclusion was that these really might be safe and good and efficacious drugs for use in pregnant women. There were 2 trials that are underway that were presented as abstracts. These are just in the blood. They did not make it onto a poster presentation, but they are in the blood edition for the meeting. One is the ADOPT trial. This is a multi-center observational phase 4, looking at real-world efficacy of avatrombopag in adults with ITP. This study is exciting to me because it's collecting a lot of data on patient-related outcomes. Because it's looking at real world, they're coming back to a lot of patient-related outcome data, and then also a lot of data on the impact of treatment. So they're doing a lot of surveys asking physicians what they feel was the impact of treatment. They're asking patients what they feel the impact of treatment has been. So really trying to get at the impact of these drugs on patients directly, not just on platelet count. And then there is also an upcoming phase 3B multicenter randomized trial that will be double-blind placebo parallel trial that will go into an open label extension phase that's looking at children. And that's really exciting for us because trying to use elthrombopag in pediatric patients has not been easy. And these are for patients that have had 6 months of ITP and an insufficient response to other treatment. So what about novel therapies? So that's the data that's come out on the things that most of us are used to using or thinking about daily in our kind of ITP toolbox. But there was also a little bit of data on novel therapies, not quite as much as there was last year at ASH, where I think there was just this explosion between the tyrosine kinase inhibitors and the complement story and these FcRNs. I think a lot of those studies are moving now onto kind of trying to get the data they need to publish. But there were still some new data coming out. So the story of the Bruton tyrosine kinase inhibitors continues. Bruton tyrosine kinase is present in signaling pathways of almost all of our white blood cells, except for our T and plasma cells, and it's an important modulator of our immune function. The one BTK that has been selected is rizobrutinib, and it was selected because it's oral and reversible, and it does not inhibit our collagen activating platelet aggregation. And that's been the problem with using BTKs in the past, is that a lot of them will inhibit platelet activation and aggregation, which is obviously not an effect we want in patients with ITP. This is the early data that was presented in 2019 at ASH, as well as the 2020 ISTH abstract, showing the phase 1/2 trial data in a very small number of patients, where they showed 33% of patients had a response and a well-tolerated safety profile. And this was looking at 2 consecutive platelet counts over 50,000. And this was 4 of 8. So anywhere from about 40 to 50. And patients received 400 milligrams twice daily. So this year, they presented ongoing phase 1/2 data now in an expanded cohort of 45 patients, as well as some long-term extension data in 16 patients. Same dose of 400 milligrams BID. 40% of patients achieved the primary outcome, which was 2 consecutive platelet counts greater than 50,000 and an increase above baseline without rescue. The duration of response, so patients were followed for 24 weeks, and a platelet count greater than 30,000 was seen for 95% of the weeks, 30,000 with greater than 20 above baseline, 86% of weeks, and then a platelet count greater than 50,000 for 72% of the weeks. So again, some data coming out on the BTKs. This again shows of those patients, the primary outcome of a platelet count response being right around 40 to 50% if we look at the primary outcome. And they didn't really see any differences across looking at how long somebody had had ITP or the number of prior therapies when they looked at a breakdown of patients. But again, a very, very small cohort, so very hard to do a lot of multivariate analysis with this number of patients. This does show that there was a slight difference. We had early responders and late responders, but you can see over time, the majority of patients were able to maintain over 50,000 or at least over 30,000. And then we had even a group of patients that for a lot of this were able to stay up above 100,000. So perhaps a promising therapy. Again, this is long-term extension data in only 16 patients. So we have to be mindful that we still need larger data, but showing some promise. And then the SYK inhibitors I mentioned earlier, and some could argue fostamatinib is not a novel therapy, but there are some novel SYK inhibitors that are coming out. Again, SYK inhibitors prevent the conformational change through pathways that are needed for a macrophage to take on the right shape to be able to do what it needs to do to cause that FC receptor interaction with the antibody-coated platelets. And it is central to signaling and B cell receptor signaling and phagocytosis. Fostamatinib has been approved, at least in the United States, since 2018 for chronic ITP with insufficient response to prior therapies. There was one study that came out looking at this in the phase 2 randomized trial. Patients started on 100 and were increased. And this is from back in 2018. This is the original fostamatinib data. Overall response rates were 43% versus 14% for placebo. When it was used as second-line therapy, so not the problem with this study originally with this phase 3 clinical trial was that a large majority of these patients had seen previous therapies, several previous therapies, even greater than 4. So this was a really refractory group of patients. So what they did in the analysis to account for that was they looked at the group of patients, the 32 patients that really got it just as second line, and showed that in that less refractory group of patients, there was a higher overall platelet count response. The most common reported AEs are diarrhea and hypertension. And in fact, fortunately, that's what made this drug relatively not well tolerated. And that persists in clinical practice, that it's just not as well tolerated as some other therapies for patients. The other thing that they did show was that when they looked at overall response, the data seemed good, but then looking at even a stable or kind of more durable long-term response, it was only 20%. So again, this data comes from highly pretreated and refractory patients, but it hasn't been a home run, I think, in terms of being a highly adapted second-line therapy yet. There is a new agent out that was an ASH abstract. This year at ASH, this is data from a randomized double-blind placebo-controlled phase trial. What they looked at was different drug dosing, and they found that the ideal dose for this drug would be 300 milligrams, and that's what they would carry forward. There was an 8-week double-blind and 16-week open label. They looked at least one platelet count during the study period of greater than 50,000, and this is the response rates based on the different doses. So the highest response rate was the almost 70% at the 300 dose. This was compared to only 9.1% of patients in placebo. But again, this was a pretty, I don't want to say a low bar, but when you're only talking one platelet count over 50,000, that's not necessarily reflective of what we desire in clinical practice. They did look, again, similarly, of those patients that got the 300 and completed study duration, 80% overall, a durable of about 30%. So maybe a little bit better than fostamatinib. The AEs that occurred in greater than 10% of patients are shown here. And then this is interesting because I think this addresses what fostamatinib had as a downside, is that 30%, almost 30% of patients experience some degree of diarrhea or some degree of hypertension. Whereas with this new drug, diarrhea occurred in 9% of patients, and that was in the 300 milligram group. Hypertension, they only reported in the whole cohort, and that occurred at 10%. So I don't know how many of those patients received the 300. So maybe this new drug will come out on the market showing at least equal efficacy, if not perhaps better efficacy, but with a much more tolerable side effect profile. The other drug that was looked at is tacrolimus. You all are familiar with tacrolimus in other settings. It's a calcineurin inhibitor that binds to the FK506. This was the Target 020 study that occurred in 140 patients. It was an open label randomized phase 2 trial in adults. And it was used as, the comparison was dexamethasone monotherapy versus a combination with tacrolimus. And this is the tacrolimus dosing here to target levels of 3 to 5. They did 12 weeks of treatment. And at day 10, they reevaluated response, and patients could receive an additional pulse of dexamethasone if they didn't respond initially by day 10. A sustained response of a platelet count of greater than 50,000 at 6 months was seen in 65% of combination versus 42% in monotherapy, which was statistically significant. The patients that were on tacrolimus also had a higher 14-day early remission rate. They had fewer treatment failures, and they had a longer duration of time prior to relapsing when therapy was completed, 77 days versus 36. They also had lower bleeding events and bleeding scores. And of note, there was no difference in treatment-related adverse events. So again, perhaps a drug we're all very used to using, but now thinking about it in a different setting. There were several trials underway that were presented with fostamatinib. The FORT trial is a multicenter prospective observational 2 cohort study that is looking at second-line therapy now. So again, like I said previously, very heavily treated patients. I think they're trying to expand a cohort now as more early therapy. Daratumumab, I know, is something that's come up. This is the DART study. This is an anti-CD38, which targets our plasma cells. And perhaps this is why rituximab doesn't bias those long-term lasting results. And there's a phase 2 clinical trial in patients who have failed at least one second-line therapy, giving 4 weekly injections. And then the LUNA-3 trial has been ongoing. This is the phase 3 evaluating efficacy and safety of RIZA at 400 versus placebo with open label extension of 12 months. And adults and adolescents. And that's in a persistent and chronic population. So a couple of really good studies underway that were submitted as abstracts to the meeting, just showing that I think there is still a lot of work in clinical trials in this area for ITP and our refractory patients. So as I said, no study would be complete without a brief discussion of COVID. And there were a couple good registries that came out looking at the impact of vaccination. So one was a combined study of the US, PDSA, and UK data, looking at patients that got dose 1 and dose 2. And you can see here about 30% increase, 30% stable, and about 30% decrease with different degrees of true exacerbation. And of this entire cohort, only 15 patients needed some degree of rescue treatment, to which they also responded. In the UK data, there was maybe an association with splenectomy, whereas with those patients having undergone splenectomy being more impacted by a decline in platelet count. I have found, and I think it's kind of interesting, I have found a handful of my patients really do have an increase in the platelet count after the vaccine. This was the Netherlands data. They compared patients with ITP and healthy controls. 6.8% of patients needed rescue medication following the vaccine. There was a greater chance of decrease if a patient was on ITP treatment prior to the COVID vaccine, and platelet count decline between baseline and 4 weeks after the second vaccine was about an 8% decline in ITP patients and a 4.5% decline in healthy controls. So even healthy controls following the vaccine will have some anticipated dip. It just might be a little bit more pronounced in patients with ITP. And then the PDSA has done a very nice online registry asking patients to contribute. They had 12% of their respondents were diagnosed with COVID, and of those, 18% had a platelet count increase, 50% were stable, and the remainder had a decrease. 10% were hospitalized. Those were mostly patients in the age group of 40 to 50 years of age. They also looked at the vaccine impact. 80% had had 1 dose and 40% 2 doses. And again, you can see here, some patients had an increase. A lot of the patients were just stable. And then about a third of patients in this cohort had a decrease. And the platelet count returned to normal or baseline within about 4 weeks in the majority of patients. So I think collectively as a whole, the message here is that the vaccine is safe. We should counsel patients and perhaps provide some surveillance, but that is a very safe thing to be giving our patients. We should be recommending it for our patients. There's no reason we should have reservations in doing so. And if patients do require treatment, for the majority of them, they're going to respond, or if they have a dip, for the majority, the platelet count will recover back on its own to their baseline values. And certainly this is a far better thing for us to handle than to truly have one of our ITP patients get very critically ill and sick with COVID itself. So in conclusion, long-term data continues to close knowledge gaps with therapies that we are currently using, including real-world data and novel uses. New agents are continued to be explored. And while randomized comparative trials remain difficult to conduct, expansion of data is starting to allow us for better parallel comparisons, including the use of patient-related outcomes, which is something very near and dear to my heart. And then lastly, COVID remains a concern for patients with ITP. However, vaccines are safe and should be administered with close observation of our patients. So I will stop there and share my favorite large platelet. I love going on platelet hunts with fellows. It's one of my favorite morphology activities. And I'll open up for any questions that you all might have.
Thank you so much. Great talk. Tremendous update.
I'm going to stop. Are you okay if I stop my screen share so I can see everyone?
Yes, yes, please.
Great.
Okay, so Before I open it to the faculty present over here, I have one or two questions related to thrombosis following.
Yes.
Do we know the exact mechanism?
I don't think we do. And I think the AVA data also supports that yet again, it's not as simple as just that bounce in platelet count, right? It's not due to the reactive thrombocytosis. Many patients have a thrombosis. We showed this in our pediatric data, even with romipilstim and elthrombopag, that there was no relationship or correlation with the platelet count. So I don't think we know. I'd be curious to look at not so much the absolute number, but is it somehow related to patients that have a higher immature platelet fraction? I don't think anybody's looked at that. So is it somehow related to a very, very robust IPF, which are these hyperactive, young, sticky platelets, regardless of what the number is? I think it's going to come down to comorbidities. A lot of it is comorbidities. I've only really, in my experience, I had one pediatric patient that had a spontaneous PE without a lot of other risk factors, which was quite scary. So I don't think we quite understand the mechanism yet. And also we know that patients with ITP are at risk for thrombosis paradoxically as well, whether that's related to the presence of lupus anticoagulants, whether that's being a post-splenectomy state. So are these patients that were at risk just from some characteristic of their ITP, not necessarily the TPO? It's a little hard to tell because we don't see thrombosis with other therapies for ITP to the degree that we do with the TPO. So there is something about the drug, right? I think we can't dismiss the drug altogether.
True. And all the three TPOs are equally responsible for thrombosis?
I think so. There's nothing that says yet one is more prothrombotic. The other concern has always been the bone marrow. I think we've sort of put to rest that these drugs are safe on the bone marrow. I think there's a large data out of the elthrombopag was the kind of most robust drug where they looked at this. That side effect seems to not be as big a concern. I think the biggest difference is the liver and the diet with elthrombopag. That just makes avathrombopag easier to tolerate, less monitoring. And I think it will eventually kind of perhaps supersede elthrombopag as a therapy.
The other question is there any predilection for particular venous or arterial system with thrombosis?
No, I mean, I think, I think most of the events appear to be venous in nature. I think, again, it comes down to probably more comorbidities that the patient has. I think, using them carefully in a patient that has a lot of other comorbidities and risk factors. I would certainly not use them in a patient that has a history of thrombosis or a lot of other comorbidities or risk factors.
And when this happens, you will discontinue TPO or whether you can restart them?
I don't think we know that answer yet. I think we all err on the side of caution and avoid them. It's really difficult. I mean, for my adolescent, this was one of the few drugs she actually responded to was a TPO. And so, after her PE, it's been challenging to now have to switch gears with therapy altogether, but very reluctant to put her on a TPO. Again, I'm even reluctant in these patients to put them on any sort of tranexamic acid when they're on their period. I really struggle with the balance then between bleeding and clotting in these patients post TPO thrombosis.
And one thing is TPO the safest of the drug if somebody needs treatment for lifelong?
That I think is the $1 million question. And I feel like the answer is maybe yes. I hate to say that because we really don't have randomized trials. And when we did the guidelines, we sort of a priori selected side effects to enter into our decision-making. The problem is we don't have comparative, nobody's collected data really on thrombosis rates with rituximab. So we don't know, but we similarly don't, we know we have low infection rates with the TPOs, and how do we balance those? They're both present, they're both rare. I do think when you talk to patients, immunosuppression is scarier to them than the rare risk of a clot, right? I do think that, and I think what some people like too about the TPOs is, for the most part, even if it's the liver toxicity of L-thrombopag, you're going to see it. You can stop the drug, it goes away. As opposed to rituximab, once we get into those side effects, we've already done what we're going to do. There's no reversing that drug or taking it away. It's kind of a big hit up front, and then you suffer your consequences that you can't see coming. But we have some milder immunosuppressants. I mean, MMF is a fairly well-tolerated therapy as well. And I think we just need a little bit more data. The FLIGHT study has been completed, was presented previously at ASH. I think the results will be published shortly, fingers crossed. And that was a study using MMF upfront. And that might give us some more data on MMF, because I do feel like compared to rituximab, the TPOs are maybe a little gentler on the system. and I think that's why they've won favor. They seem, everybody, the side effect seems relative, the profile is relatively well tolerated for the majority of patients.
And success-wise, MMF is a poor choice than TPO, the success rate.
I think we have to see and unfortunately, like I said, the FLIGHT trial was an upfront, so it wasn't necessarily a direct comparison. I still think the TPOs have probably the highest and sustainable for a lot of just from experience, we all know it's very rare that patients lose their response. And usually when they do, I think it's because they tire of taking the medicine. And if you really track it back, it's adherence related. There are some patients that remain adherent and still lose the response. What I will say with the TPOs, and maybe it's a little bit different than the immunosuppressants, but it is a bit of a roller coaster for some patients. But I've learned if I get a patient that dips to 20, I don't dose adjust them. I just let them sit there, and usually by the next week or 2 weeks, they're back to where they were. I have really stopped. That nomogram drives me batty. I've really stopped and I look at my patient and sort of, right. And I also know which patients bleed when the platelet count goes low, which ones can tolerate a dip. Sometimes if I get a 1 time, 2 times, I also set a goal with the patient, and I say, what platelet count is going to make you happy? The label says aim for 50,000, but if you're happy at 30 and it's a lower dose and we don't have to go up on the dose to achieve 50, we can sit there,
Thank you. Dr. Prashant.
Yeah. Very good morning, ma'am. It was a fantastic lecture. Learned a lot. I have 2 questions. One is on the role of Ritux. Now, when we give Ritux, there are 3 scenarios. One is where patient goes into a CR, which is fantastic. Then there is a patient, a small subgroup who doesn't respond at all. And then there is a subgroup who partially respond, maintain a platelet count between 30 to 70,000 and do reasonably well over a period of time. So in that kind of a subgroup, do you suggest a repeat dose of rituximab after some time, just like what they do in rheumatologists do it in SLE or rheumatoid arthritis?
Yeah, I have given sort of, I guess, a booster dose. I'm more familiar. I've used it. I actually had a patient with TTP, and that was what seemed to, like, once a year, she'd kind of relapse and we'd give her a dose of rituximab and she'd go back into remission, and it would last for a year. And there are other settings where they do this. They also use lower doses, slightly lower doses. And I've never repeated a full course. I've kind of just done a one-time dose. I think only because my concern is I don't think we know how that increases the risk of PML is really what's in the back of that's what is always in the back of my mind. I think in terms of efficacy, there's been some data to suggest it does work really well in the adolescent and young adult female patients compared to other patients. That seems to be a group that is responsive to rituximab. We just had a lovely lecture. There's a group out of Atlanta working on sort of who responds and who develops. The other concern is this persistent hypogam after Ritux. And that appears to be more related to patients that have undiagnosed immune dysregulation. So they look like an ITP patient on the surface, but you dig deeper and they actually have some sort of primary immune deficiency or immune dysregulation. And those are the ones that Rituximab seems to not be ideal in. I also really love rituximab in any patient that's got secondary ITP with a related rheumatologic condition, because it's, treating both at the same time. There was a lot of debate around rituximab when we worked on the guidelines, because there was a very strong group for the TPOs are so safe and so good. But then there's a group of, when you look at rituximab, it does delay, it's a drug-free remission, as you said, for a lot of patients. And even if they don't achieve a full remission, they have a much better quality of life without the need for ongoing therapy. So.
My other question is, in the refractory ITP, do you think bortezomib has a place?
Which drug?
Bortezomib.
Yeah, so bortezomib is a really, and they're looking at daratumumab. I think bortezomib also potentially has a place. The place where it's being used currently is with refractory ITPs or other cytopenias post-transplant. There we have done bortezomib. And I think it's a weighing the side effect profile, right? Or sort of what you're willing to suffer. I think the DARA is an interesting story because of the plasma cells. And there's been a long-standing argument that that's the component that rituximab isn't handling. And so you're just eventually this sneaky little population breaks free and your ITP comes back and you relapse, versus if you go after the plasma cell category and really kind of delete that memory a little bit more. So I think DARA and bortezomib, drugs that we're starting to use in the transplant setting or other immuno settings are going to make their way to ITP as well.
Bortezomib, the dose used is just same, weekly dosing of 1.3 mg.
I've used it twice in post-transplant, and we used the same dose. We just used a standard protocol. And again, I think that's the other problem that we encounter with some of these drugs and translating them to ITP is, even rituximab, we follow the oncologists. Maybe we don't need to follow the oncologists. We're not treating cancers. We're not treating clonal populations. We're just trying to modulate. So maybe a little different.
Thank you, ma'am.
Thank you, Dr. Amrita.
Thank you, sir. It was a wonderful, informative lecture, Dr. Cindy. Congratulations and thanks a lot for updating us. Actually, my question is, how frequently do you suggest monitoring of platelets should be done in a case of acute ITP in a patient who has recently recovered from COVID-19?
Yeah, so in the pediatric world, we tend to minimize checking. I think if we look, most of the decline in platelet counts, vaccine at least, which is what we have more data on, I think, than COVID-19 infection itself, occurred within about the first 2 weeks. If there was going to be a decline, and then they recovered by about 4 weeks. So, if you check, even what I've said with vaccine anyway is, obviously if you notice symptoms, we're going to check you. And then if you have developed, if you get the vaccine and we want to check, probably somewhere around 10 days or so is a reasonable time to just check. Mostly I base it on symptoms. In the adults, I think they're kind of checking around that same time period, sometime post 2 weeks is the recommended surveillance. For infection, I think it just depends on the patient and the degree of symptoms, the degree of thrombocytopenia. For a standard acute ITP, I usually like to see them back within the week, to check for that response to therapy. But if they're really bleeding, you're going to be checking much more frequently than that. Yeah. And then I try, as soon as as soon as I see that they're not bleeding, their platelet count is doing some degree of either stable or improving, I tend to try to space them out and particularly with COVID for us anyway, it's becoming increasingly difficult to bring COVID positive patients to our clinic. We are getting to the point where some days we have no rooms to see patients because everybody requires isolation. So actually we're doing a lot more just if you're not symptomatic, as long as we have seen that you're doing okay, better you remain at home and continue to quarantine too, is the other struggle with post-COVID, right?
Yes. Thank you. I have one more question. Like, suppose it's a pregnant female, even though the no comorbidities, and I understand like we need to assess the patient's clinical condition and the comorbidities, but the similar scene of situation with the pregnant female. So should it be done same duration, or would you make any change in the time?
I think for pregnancy, I might monitor just a little bit closer, right? You have 2 patients that you have to worry about, not just one.
Right.
So perhaps in that setting, a little bit closer monitoring until you at least, again, know that you're in a safe number from the standpoint of the pregnancy, would be prudent.
Would you like to do a bone marrow at some point of time? Any particular indication for going for a marrow? Like if you really don't know obvious cause?
Yeah, so in both adults and in children, we've really sort of shied away from bone marrows with typical features of ITP. Anybody who has atypical features certainly merits a bone marrow. There's been a lot of work done out of McMaster on surveillance marrows in adults with ITP, showing that it was really unlikely that you were missing something else. I think the older age group is still the debatable, the over 60, where you do start to have a lot of other hematologic processes that could be driving it. And even in pediatrics, we used to think, oh, if they didn't respond, we should do a marrow. I think it's more the atypical features that should drive the bone marrow.
Okay.
And it's no longer recommended before starting a TPO either.
One last question. Like any role of immature platelet fraction with, in such a setup, how much importance do you give them?
Yeah, so my center actually just recently, within like the last year and a half, started reporting out an IPF. And I actually like it. It's very similar to the retictomy. I get a sense of reassurance if I have a patient with a platelet count of 10,000, but an IPF that's 45, that is a marrow that is working. So I do find it helpful as a marker. There was an ASH abstract that I didn't present where there's also groups looking at IPF in relationship to response to different therapies. I also find it's interesting. I have some patients that don't respond platelet count wise to a TPO, but their IPF goes up. Their platelet count might still be 5,000, but now I'm getting an IPF of 35%. And the oral mucosal bleeding they had has stopped. And I kind of put them in a bucket of a clinical responder, and I haven't stopped their TPO because it's doing something. Right. They may still have the same platelet count, but it's doing something. They definitely come to clinic a different patient. And that's why I think maybe it's that IPF that just getting a healthier population of platelets, is the difference.
Great, because we also do believe in IPF, and I think it helps a lot. And may I know what is the cutoff you are using there? The cutoff.
I'm sorry?
You call it high. The cutoff for IPF percentage?
I think I want to say our IPF cuts off at like our normal range goes to like 6% or so, maybe.
Because we take around 6.8%.
Yeah, I was going to say it's like 6 or our
right.
lab sets our cutoff, and I think it's around 6% for a normal.
Right. I know it has to be laboratory based.
Yeah.
Okay.
And it's also, it's also relative. It's sort of like the retic, right? You always have to put it in the context of your hemoglobin, a retic that's 4 with a hemoglobin of 5 is not appropriate either. So I'm always like, yes, they say it's a high retic, but it's not an appropriately high retic. So
thank you so much.
Yep.
Dr. Neeta.
So, thank you, Dr. Neunert, for this very informative talk. I have few doubts. So if you have a pediatric patient with ITP, Do you do any biological correlates which can tell you whether this will be, which it will be headed towards chronicity? Like there were some trials or studies on cytokines or looking at Tregs, etc. So do you do anything in your practice?
So I don't. I am contributing to a biology study that's being run by Jenny Despodovic out of Baylor through that ICON network that we talked about, that I think is now excitingly up to about 50 centers. And that is really, I think, going to be the next direction we try to go. We are also from the ICON study looking at upfront L-thrombopag. We have a standard of care arm, and we're getting biological correlates on all of the patients that are enrolled on that study. So we'll learn some information from the standard of care arm as well. But to date, there's really no biologic predictors. There was a study looking at sort of CRP and SED rate as markers of chronicity, but I think there were a lot of flaws in that really haven't adapted it to standard of care at this time. I do always, I'm a little more cautious when I counsel the adolescents. That just alone, you know, as a clinical predictor, not necessarily a biologic one, but our hope is to move towards that. Well, there was an abstract that came out looking at what's called machine learning, where it's these machine built prediction models. And that's one of the things they're trying to do with the Baylor data set is to see if we can build these machine learning prediction models where you enter in different variables and it kind of calculates in a very fancy way a prediction model for chronicity, but we don't have it yet. And I don't think we really know from adults either who it is that relapses off steroids and who is responders.
Okay. In your practice, do you still follow splenectomy for patients?
I have not done a splenectomy on a patient in a really long time. I actually felt bad because I'm part of the intercontinental group for ITP, and I contributed not a single patient to their splenectomy registry. I certainly wait until patients have had ITP for quite some time. I do discuss it with families when I'm talking about second line therapies. A lot of families really hedge away from it. They don't want it. And I find that my most refractory patients are likely the ones that I'm very nervous are not going to respond to splenectomy. They've not responded to anything. And I get very nervous to think all of a sudden splenectomy, I feel like they're the group that's going to fall in. And I also get nervous that that's a group where I'm just missing something. I typically will refer them to rheumatology and immunology. We check them for primary immune deficiencies. But I feel like, again, there's an area of discovery where are these just patients that have an unclassified immune process, and taking out the spleen isn't going to change that in any way, and may even work against them. So I'm very reluctant to do splenectomy. I still think there's patients that need it. You know, if you come in with an intracranial hemorrhage, then we're going to take out your spleen because we need to. So for life-threatening bleeding, it's still very appropriate therapy in pediatrics. But I think most of us don't conduct splenectomy regularly in patients anymore.
Yes, well, just one more doubt regarding rituximab in patients with primary immune deficiencies. So if you have a primary immune deficient, like a CVID or some kind of patient who has a very refractory ITP, would you consider rituximab? Like they're already on an IVIG replacement schedule. So.
Yeah, so for a child that already has a diagnosis of CVID, actually, this does seem to be good therapy. It's the children where they don't have manifestation. I think it's important to check immunoglobulins before you give rituximab, just so you know where you are. But then what they were finding was it's other signals of kind of immune dysregulation that are the patients that ended up getting that common variable post rituximab. And that's what I think is just hard when you take a child who's healthy, you give them rituximab for their ITP, and then, oh, by the way, now they're on IVIG replacement. And we don't know, for some patients that can persist for years. So there are people trying to look at if we can pre-identify those patients that will not reconstitute gamma globulin post rituximab.
My question was already diagnosed primary immune deficiency.
Yeah, I think if it's
other modes, so would you be comfortable giving rituximab to such a
yeah,
patient?
if it's an already CVID patient, I would. That's the one in which I think I would. Other primary immune deficiencies, I usually have a very good discussion with the immunologist because sometimes there's better targeted therapies based on what their what their immune deficiency is.
Okay. Thank you.
Thank you. Dr. Ankit.
Yeah, thank you, sir. Dr. Neunert, thank you for the lecture. And my concern is regarding the activating antiplatelet antibodies that may be present in some of the patients of ITP. Do you believe in that hypothesis that some of the patient might be having antiplatelet antibodies which might be activating the platelets and might be putting them at the risk for thrombosis, especially if we introduce TP agonists early?
Yeah, so I think the role of antibodies in ITP can go two ways, right? Either it's interfering and that's what's causing bleeding events, or perhaps is it something where they're targeting something that, again, is making the platelets hyperactive, almost like a hit situation, right? Where we see this paradoxical thrombocytopenia and then we do know the underlying, there's also patients that have an underlying lupus anticoagulant as well. I think part of our problem has been just the inability to really have good testing for the antibodies in ITP to begin with. John Semple is working on developing newer ways and more reliable measures for checking the antibodies. And I think that will let us kind of enhance what we know about those antibodies. There's a lot of studies that are open right now. And there was an abstract at ASH kind of looking at predictors of bleeding. I don't think as many people have looked at the predictors or the role of antibodies in thrombosis, which is actually an interesting flip to it if we use HIT as a model. So I don't have an answer to that. I do know people are looking at them in terms of bleeding risk.
And my second question is, when you are using TPO agonist upfront, are you facing increased thrombosis occurrence in your ongoing trial? Would you be able to share?
So it's a pediatric trial. I'm on the safety board, so we have not had any, and we're using L-thrombopag in that setting in pediatric patients. We have not had any reports of thrombosis. And I don't believe in the upfront studies that have been done. And in the study by Newland that just presented a little bit of upfront, looking at the subset, there wasn't an increased concern for thrombosis from that abstract. And then in the L-thrombopag dexamethasone study where they gave pulses of dex alongside a 21-day course of L-thrombopag, I don't think they had any increased incidence.
Right. And the third question is regarding a patient who has been in long remission and was relapsed after a long time and is coming for bleeding episode. So would you be comfortable in using TP agonist in this particular patient upfront, or would you start with immunosuppressive and decrease the antibody titers?
The relapse patient is tricky because it's almost, do you consider it do you treat them like a newly diagnosed patient, or do you just treat them? Sometimes if they were on a therapy in the past that worked, I go right to that. Otherwise, I think it is fair I had a patient that relapsed that we gave one course of steroids and she went straight into remission. So I do think it's worth coming back to at least a course of corticosteroids to see, because you don't know what the trigger was for that relapse. And maybe it was a transient trigger. So I've been inclined to try to just stick with first line again, see if I can get them into remission. If I can't, then I move on to second line.
Right.
Unless it's not been much time has elapsed and I know what they responded to. And I think it's more just that we stopped their drug and this is kind of more a chronicity. But if it's a true new trigger, it may be something transient that they get over quite quickly.
Right. Thank you.
Thank you. Dr. Priyanka.
Thank you, sir. So my question is, what dose of L-thrombopag do you recommend in children? The minimum dose of L-thrombopag to start with?
Yeah, so I'll usually start, depending on age, and wait at either 50 or 25, and then advance up, depending on response, to a max of 75. And then I apologize that I haven't, for the younger children now, there is dosing based on weight, and it's different for each age group, and it's based on the liquid preparation. And I just kind of follow the guidelines of the dosing for that. Okay. And that came out of the Petite and Petite 2 studies, were the dose finding studies for that. particular drug. I can say I actually have not used a lot of L-thrombopag for my younger children. Mostly I do it in the adolescents. Most of the younger children, the parents would much rather do once weekly Ramipulstim than try to get their child to take a drug every day. And the dietary restrictions have just not been ideal. So most of my younger children are on Ramipulstim. And we get them trained to do it. The parents do it at home weekly, and it's really nice. But for L-thrombopag, if I do start it, I just reference what the dosing is for that particular age group.
Okay. My second question is, what is your take on use of rituximab in a refractory ITP? We have an adolescent female who has been diagnosed as SLE with autoimmune hemolytic anemia and refractory ITP. She was initially on Romiplastim. She showed her response to, there was an increase in platelet count, but slowly she lost her response to maximum dose. Then we changed it to L-thrombopag. And now also the same thing is happening, that she is losing her response to L-thrombopag. So what is your take on use of rituximab in this child? Because she's hepatitis B positive. So do you use any cutoff titers for hepatitis B to use rituximab, or you just go ahead with rituximab in this?
Yeah, so I am fortunate that I've not encountered the hepatitis B story. That is sort of a contraindication to rituximab.
Yeah.
Were it not for that that plot twist at the end there, I would have said that rituximab is a perfect drug for her. She's exactly the kind of patient I think responds, right? The adolescent female, underlying lupus, also has AIHA, so that's going to help with that. It's that reactivation of the hepatitis that I would be worried about, in which case maybe you could reach out to your ID folks and just kind of see what they think. Because again, that is sort of a relative contraindication to using rituximab because of viral reactivation of hepatitis. So,
okay. Thank you, ma'am.
Thank you.
Yeah.
Tushar. Unmute, Tushar, unmute.
Sorry. Thank you, sir. Thank you, Dr. Cindy. My question is on COVID, actually. So in COVID patients, we know that there's life-threatening coagulopathy. And in these patients, we give aggressive anticoagulation. But there is also a risk of HIT, heparin-induced thrombocytopenia, and consequently thrombotic episodes. So the balance of balance of anticoagulation is outweighed, and so do you recommend routine testing of PF4 antibody for the detection of HIT in these patients?
Yeah, so we have not been routinely screening for those antibodies unless a patient develops kind of a picture that looks like HIT. Again, because there can be false positives with the antibody, and then you have to go on to do the serotonin testing as well. We have been doing a lot of anticoagulation prophylaxis though. So almost every patient that hits our adult or pediatric unit with active COVID, symptomatic COVID, is getting on some form of prophylactic anticoagulation. In the adults, they're using DOACs, which kind of gets around the risk of HIT. We unfortunately in pediatrics can't use all the DOACs yet, so we use a lot of Lovenox, which presumably has lower HIT risk. In any patient though who develops thrombosis, drop in platelet count, obviously working through the 4 Ts and deciding if HIT is appropriate and switching anticoagulation. The other thing that has come up is the thrombosis events following COVID vaccine that appear to be PF4 mediated. And I have sent off testing in that setting to see if it seems to be a vaccine related thrombosis or not. I've had one patient with very extensive thrombosis that occurred. And it's a little hard, they came to me too late to send it. I sent it and it was negative, but it was months after getting the vaccine. So who knows? But that's another setting where I think it's useful to be able to send the HIT is if you think it's a vaccine associated thrombotic event.
Yeah. Okay. And my second question is about the laboratory aspect. Is there a morphological difference between giant platelet and large platelet?
So I think they're both the same. I think macrothrombocytopenia can be for any different. I think that when you see big platelets, right, what you're really trying to establish, and often, I mean, the degree of thrombocytopenia should also be a clue, but what you're really then trying to distinguish with platelet morphology is, does the rest of the platelet morphology look okay, or are there other clues that you're not dealing with macrothrombocytopenia in relationship to reactive from ITP, but more a congenital, Bernard-Soulier, May Hagelin, gray platelet. So do you get other morphological clues? And usually that's in the setting where I start to see that on a patient with mild thrombocytopenia, over 50% of their platelets are bigger than the size of, a red, you start to see about at least half of their platelets have this really large platelet. But no, I refer to them. I always tell the fellows, I'm like, just go find me a big, big juicy platelet. So I use even less technical terms.
Yes. And sorry, the last question is, can we do platelet function studies in COVID patients with platelet count of less than 1 lakh?
Yeah, so doing
because
platelet,
it is quite tricky.
Yeah, no, doing any kind of platelet function when you have thrombocytopenia, even in a healthy patient without COVID, is extremely difficult and has been one of the limitations in us being able to really do the correlates of why certain patients with ITP bleed, right? Because we think it might be platelet function related, but we can't test them that way. So instead, what people look at is more flow cytometric kind of platelet activation markers, but those aren't clinically available. So there are some centers that have relied on TEG and ROTEM as sort of kind of looking at the whole fibrinolytic system and trying to gauge maybe what's going on with platelets, but true platelet aggregation. My lab won't even let me order them if the platelet count is under 100,000. Like I would have to beg and plead with them. So it's kind of hopeless.
Yeah. Thank you.
Dr. Ritika.
Thank you, sir. Thank you, Dr. Cindy, for a wonderful talk. We have a 13-year-old female child who was diagnosed with chronic ITP more than a year ago, and she's steroid responsive. So we gave her a short course of steroids, and twice she has received short course steroids. The girl was doing well. She was not bleeding, although the platelets kept less than 10,000 always. But she came with a spontaneous IC bleed 1 month back. And so we gave her steroids and IVIG, and no neurosurgical intervention was required. And within a 1 month's time, again, like 3-4 days back, she came with another spontaneous IC bleed. So, madam, will this child benefit with splenectomy? And if not, then which other therapies should we try for her? Because TPO agonist we couldn't use for a long time because of financial constraints. So.
And I'm sorry, I know you said at the very beginning, how old is she again?
13-year-old, adolescent girl.
Oh, poor child. I guess one thing I would also do is make sure that, neurology has really looked to make sure there isn't any sort of vascular kind of abnormality, and or working with rheumatology to make sure there isn't some other reason why this poor child has had 2 spontaneous ICHs, which is quite rare. I do think for her, she would be the kind of patient that would benefit from splenectomy if other therapies are financially not an option. And honestly, she's somebody that clearly can't tolerate a lower platelet count. I mean, we always say in pediatrics, oh, we don't really worry about the platelet count, but I always say you've got to look at the whole patient. And, if it's a patient that's had a significant bleed in the past, there's no way I'm going to let that patient live at a low platelet count. So splenectomy for her might be the best next step, to really prevent her from having these dips in the risk for ICH and without a financial burden to the family. Yes, I still think splenectomy is good therapy. Jim George says it all the time. It still works. It's still good.
Thank you, ma'am.
Thank you. One last question is from the audience. Recently, Blood carried that Chinese article on ATRA with a commentary, all trans retinoic acid. So Dr. Jain wants to know that how does ATRA work in ITP?
Yeah, I think that's a great question. I got excited because I thought there was another ATRA abstract, and then I realized I just found the one from I think it was last year. There was a big ATRA story. It's really only been in very small groups of patients that they've looked at ATRA. I don't think we actually understand. The other reason why a lot of people have sort of been skeptical is that nobody fully understands how ATRA works and what it's doing. And so the biology doesn't seem to support it as an agent. And so I think that's made some people skeptical too. And it's been in very small numbers of patients where they've used ATRA. So.
Well, thank you so much, Dr. Neunert. You have been with us for the last 90 minutes and you have.
Always a pleasure. Always a pleasure. Such good conversations. I love it.
Indeed, grateful. Have a lovely day.
You guys have I guess it's evening time there. So have a lovely evening, everyone. I will go have my coffee and you all can go have dinner and dessert.
Bye-bye.
Bye-bye.
So I'll just share my screen to introduce the next speaker. So the next lecture is on BRAF V600E mutation in hairy cell leukemia from bench to bedside. And you have heard him just a couple of months ago for AML and mutation. And now he's with us, Dr. Professor Falini, Director, Institute of Hematology, Bone Marrow Transplantation from Italy. Pioneering work in the field of monoclonal antibodies, contributions to the development of modern classification of lympho-hematopoietic tumors, first immunotherapy with anti-CD30 immunotoxin in Hodgkin lymphoma, recognition of ALK plus anaplastic large cell lymphoma as a distinct entity, molecular characterization of AML with normal cytogenetics, the discovery of NPM1 mutation and its translation in clinics, molecular characterization of hairy cell leukemia and the discovery of BRAF V600E as the underlying genetic lesion. Of course, that's what he's going to speak to us today. Development of new molecularly targeted therapies for BRAF inhibitors in refractory relapsed HCL. And once again, that probably is going to cover. He has authored more than 350 peer-reviewed publications in internationally recognized journals, as well as several book chapters on lymphomas and leukemias. Moreover, he serves as a reviewer for major scientific journals. H-index 94, the Institute of Scientific Information, Philadelphia, has listed him as a highly cited researcher in the field of clinical medicine. He's a member of the Group 2003 that includes the most cited Italian scientists in different fields. He's a recipient of numerous research grants from several institutions, including the Italian Association for Cancer Research, the French Art Foundation for Cancer Research, and the Hairy Cell Leukemia Foundation. The Jos Carriers Award 2010 from the EHA, the most prestigious prize in hematology in Europe. The Karl Lennart Lecture Award from the European Association of Hematopathology Lisbon 2012. The Leopold Griffel Prize 2014 from the French Association for Cancer Research, the leading prize for cancer research in Europe. The Guido Venosta Prize 2014 for the Italian Federation for Cancer Research, the most important award for cancer research in Italy. The Adolfo Ferretta Lecture Prize Florence 2015 from the Italian Association of Hematology. Member of Scientific Committee, AIRC, ILSG, International Lymphoma Study Group, Clinical Advisory Committee for the WHO Classification of Lymphoid Tumors, Clinical Advisory Committee for the WHO Classification of Myeloid Neoplasms, Clinical Advisory Committee for the WHO Classification of both lymphoid and myeloid neoplasms. This part of our webinar is supported by MedGenome. I stop here, and Dr. Falini, it's all yours now.
Right. Hi, Dr. Agarwal. How are you?
Fine, sir. Thank you.
Thank you. Can you see the slide?
Yes, sir.
Okay. Okay. So first of all, I would like to thank you for the kind invitation to the Best of ASH meeting organized by the Mumbai Hematology Group. This is my disclosure, and the title of my presentation is BRAF mutation in erythroid leukemia from bench to bedside. I would like to try telling the story, going from the lab directly into the translation into patient with targeted therapy. Erythroid leukemia is a well-distinct clinical pathological entity that derives its name from the typical airy projection on the surface of leukemic cells, as you can see in this smear. On the bone marrow biopsy here, erythroid leukemia shows the characteristic on a camp pattern in which nuclei of cells are quite far away one each another because there is a large amount of cytoplasm in between these nuclei, as occurs in erythroid leukemia cells. On the other hand, in liver sections, you can see that the infiltration pattern of erythroid leukemia is typical intra-sinusoidal, whilst in the spleen, erythroid leukemia among B-cell lymphoma is the only one that involves selectively the red pulp instead of the white pulp of this organ. In my presentation, I will first briefly review the molecular pathogenesis of erythroid leukemia. Then I will deal with the diagnostic challenges of this disease. And finally, I will discuss the new therapeutic perspectives with a focus on BRAF inhibitors. Here are summarized the typical features of this pathological condition according to the 16 WHO classification of lymphoid neoplasms. In particular, erythroid leukemia occurs in adults, older people, median age 55, with a male predominance. The male-female ratio is about 4 to 5 to 1. And patient usually present with an indolent cause associated with pancytopenia and monocytopenia. A splenomegaly in the absence of lymphadenopathy is present in 85% of cases. Erythroid leukemia is highly responsive to purine analogs, that is to cladribine and pentostatin. And as already mentioned, it shows distinctive morphological features. Moreover, the leukemic cells co-express B-cell antigens such as CD20, CD22, and CD19 with other markers such as CD25, CD11C, CD103. About 85% of the cases carry mutation of the immunoglobulin genes. Most likely, erythroid leukemia derives from memory B cells, as we demonstrated in the past by using gene expression profiling. And as I will show, virtually all cases carry a BRAF V600E mutation, as we reported about 10 years ago. How we discover this mutation? 10 years ago, at the beginning of the whole genome sequencing era, we decided to perform whole exome sequencing of the leukemic cells purified from a patient that was admitted in our clinic, comparing the sequences with the normal neutrophils purified from the same patient. We came out with 5 variants in the leukemic cells as compared to normal cells. And among these variants, we focused to the BRAF mutation that was one of the 5. With extremely rare exception, the mutation occurs at exon 11 of the BRAF gene, leading to a phosphomimetic amino acid substitution that is valine with glutamate at position 600 in the activation segment of the tyrosine kinase domain of the BRAF protein, which is the enzymically active portion of the protein. Here, I'm going to explain you which is BRAF. BRAF is serine threonine kinase of the MAP kinase pathway, and under physiological condition, BRAF is activated by the binding of a given receptor tyrosine kinase with its ligand, probably in the microenvironment. This leads to activation of BRAF via RAS, and BRAF in turn is a major activator of MEK1 and MEK2, which are located downstream components of the MAP kinase pathway that in turn are phosphorylated and can therefore lead to activation of ERK that can translocate into the nucleus of the cells, promoting proliferation and survival. What is important to remember is that these signals physiologically are self-limited and triggered by the interaction by the ligand present in microenvironment with the receptor tyrosine kinase present on the surface of the cells. However, BRAF was shown at the Sanger Institute to be mutated in about 50% of melanomas and about 40% of papillary thyroid carcinomas, and in a smaller percentage of solid tumors. However, is remarkably, BRAF is the kinase encoding oncogene, which is most frequently mutated in human cancer. However, this mutation is exceedingly rare in hematological tumors, with the exception of early cell leukemia, in which virtually all cases carry the BRAF mutation, and in the Langerhans cell histiocytosis, where about 60% of patients carry this mutation. What is important to remember is that this mutation, unlike physiological stimuli triggered by the interaction of the ligand with the tyrosine kinase, leads to a constitutive activation of the MAP kinase pathway, and therefore to continuous promotion of survival and proliferation. And this is the major key molecular event in the molecular pathogenesis of disease. More than 90% of the mutation are TA transversion at exon 15. And as already mentioned, these result in the phosphomimetic substitution in the tyrosine kinase site of the BRAF molecule. The fact that BRAF mutation is the disease-defining genetic event in hairy cell leukemia is supported by a number of evidences. First of all, it virtually occurs in almost all hairy cell leukemia patients, including all clinical pattern of the disease, that is patient with leukopenia, but also with leukocytosis, with and without splenomegaly. And in the single patient, mutations are somatic and present in the whole cell population, as you can now demonstrate also in bone marrow biopsy by immunostaining with monoclonal antibodies directed against the BRAF V600E protein. Moreover, the mutation is detectable in body cells which are rarely involved by the disease, such as lymph nodes or other organs. Notably, the mutation is very stable, and we were able to demonstrate the mutation by molecular techniques and immunohistochemistry even 20-25 years after the initial diagnosis in hairy cell leukemia patients. Finally, among B-cell lymphoma, the BRAF mutation appears rather specific for hairy cell leukemia, highlighting this mutation as a potential marker for differential diagnosis among these conditions. Based, in fact, on this observation, we set up the first molecular diagnostic assay for hairy cell leukemia based on the detection of the BRAF mutation in the peripheral blood or bone marrow of patient using a sensitive allelic specific PCR method with sensitivity of about 1%. This assay is able to distinguish hairy cell leukemia, where is always detected from other hairy cell leukemia-like disorders that show frequently a hairy morphology and even splenomegaly, such as hairy cell leukemia variant, splenic marginal zone lymphoma, or red pulp splenic lymphoma. As you can see in this image, you can see here the positivity for the BRAF mutation and negativity in this case. More recently, the availability of a monoclonal antibody specifically directed against the BRAF V600 mutant protein allows also to perform molecular diagnosis by immunohistochemistry in formalin fixed, paraffin embedded bone marrow biopsies by immunostaining, as you can see here, of the tumor cells with an antibody specific for the mutant protein. These findings establish the criteria for separating hairy cell leukemia, classic hairy cell leukemia, from other disorders simulating hairy cell leukemia, such as hairy cell leukemia variant and other unclassifiable splenic lymphoma, such as splenic diffuse red pulpy lymphomas. There are included as not definitive variant entity in the WHO classification of lymphoid tumors. How can distinguish this condition? The hairy cell leukemia variant, as shown in these peripheral blood smears, differs from hairy cell leukemia because it is usually characterized by leukocytosis instead of leukopenia or pancytopenia, as you have in hairy cell leukemia. However, you should remember that about 15% of cases of hairy cell leukemia may present with the leukocytosis. And characteristically, hairy cell leukemia variant has also no monocytopenia, which is a characteristic of hairy cell leukemia. Moreover, the leukemic cells, as you can see here, can show a very well distinct nuclei, one or more, in the context of a mature chromatin. So in a way, you have some morphological criteria and laboratory finding to distinguish this condition that, however, are not always very effective. The definitive diagnosis is by immunohistochemistry using an immunostaining against annesin-1 that can be performed on paraffin embedded samples, because in hairy cell leukemia, annesin-1 is strongly expressed, whilst in hairy cell leukemia variant is negative. As a matter of fact, we demonstrated in a paper in Lancet in 2004 that annesin-1 is specifically expressed among normal B cells and B cell lymphomas only in hairy cell leukemia. So it's very specific marker. In addition, now you have also, you can study this case with BRAF mutation, because this is present in hairy cell leukemia but absent in hairy cell leukemia variant. Distinguishing these two conditions is very important because the treatment in the two conditions, it can be different. Molecularly, hairy cell leukemia variant has been recently shown also to be associated with different mutation. In fact, in about 50% of cases, these patients carry mutation of the MAP2K1 gene that is encoding for the MEK1 protein that, as you may remember, is the one of the downstream component of the MAP kinase pathway. So it is very interesting that another mutation involved in the pathogenesis of B-cell disorders with hairy morphology, such as hairy cell leukemia variant, is occurring in a gene encoding a component of the MAP kinase pathway. Moving to the therapy of hairy cell leukemia, this has dramatically evolved over the last 15 years, going from simple splenectomy 50 years ago to interference in the early 80s, to purine analogs, pentostatin and clavibrin, plus minus rituximab in the early 90s, to the anti-CD22 immunotoxin moxetumomab in the early century, to the BRAF inhibitors, I would say 5 to 10 years ago. As compared to interferon that only at beginning resulted in partial remissions, purine analogs are usually associated with completed remission in about 85% of hairy cell leukemia patients at first diagnosis. However, as you know, 40 to 50% of hairy cell leukemia cases who achieve a complete remission relapse after a variable period of time during the course of the disease. This algorithm shows the approach to refractory relapsed hairy cell leukemia. And I would say that for patients whose first relapse occurs more than 2 years from the initial complete remission, we can advise treatment with a purine analog again, with addition of rituximab. In fact, this study from UK shows the excellent relapse-free survival of relapsed hairy cell leukemia patient treated with purine analog plus rituximab. Notably, the relapse-free survival was even longer with this combination of drugs that with the purine analog alone used as a first-line therapy. Similar results have been reported by Dr. Farhad Ravandi at the MD Anderson Hospital. Going back to the therapeutic algorithm for hairy cell leukemia patient at the second relapse, more than one relapse, let's say, there are two possible therapeutic options. If the patient relapse more than 5 years after achieving complete remission, we can even at the second relapse, in my opinion, consider purine analog with the addition of rituximab. However, in all other cases, either vemurafenib plus rituximab, that in my opinion now should be the standard of care, or moxetumomab pasudotox, that is the anti-CD22 immunotoxin should be considered in these cases. And let's discuss the moxetumomab first, that is called also Moxe. This is a fusion immunotoxin which is made up of the fragment of the variable portion of the anti-CD22 monoclonal antibody fused to the portion 2 and 3 of the Pseudomonas exotoxin. After binding with the CD22, which is strongly expressed on the villi of the hairy cell leukemia cells, the immunotoxin is internalized in the cytoplasm of the tumor cell and processed within the endosomes, where the antibody part is separated from the exotoxin molecule that in turn move to the endoplasmic reticulum, where the protein synthesis occurs, inhibiting this process, the protein synthesis, and therefore inducing apoptosis of the leukemic cells. In the registration trial, Moxe was administered to 80 refractory relapsed hairy cell leukemia patients at the dosage of 20 micrograms per kilo for 3 days every 4 weeks for a total number of 6 cycles. The overall response rate was 75%, with about 41 complete remission and only 34% of MRD negative complete remission. A grade 2-3 hemolytic uremic syndrome was observed in about 5% of cases, and the capillary leak syndrome in about 2% of cases. That sometimes were problematic to treat. The drug has been approved only in United States for the treatment of hairy cell leukemia refractory to relapsed after 2 or more prior lines of therapy. Moxetumomab is not available in Europe for therapy of refractory relapsed hairy cell leukemia. BRAF inhibitors such as vemurafenib and brafenib represent, as I mentioned, another valid option. However, before going into a clinical trial, we needed to test preclinically the activity of this compound, and this was indeed not easy for 3 reasons. The first is that so far do not exist true hairy cell leukemia human cell lines. What have been described hairy cell leukemia human cell line are indeed not hairy cell leukemia cell lines because they do not carry BRAF mutation. No animal models of hairy cell leukemia exist. Third difficulty, patient present often with marked pancytopenia. So in order to study the effect of the drug in primary tumor cells, we had to take up to 60-80 ml of blood to be able to purify the hairy cell leukemia cells and to investigate the activity on leukemic cells with the BRAF inhibitors. Our expectation in this situation would be that incubation of purified primary hairy cell leukemia cells with BRAF inhibitors, either vemurafenib or dabrafenib, would have in a way reverted the effects related to the constitutive activation of the MAP kinase pathway mediated by BRAF mutation. First of all, of course, would have reverted the increased phosphorylation of the downstream signaling MEK and ERK located downstream of mutated BRAF. And this, in fact, what is occur. In fact, incubation of hairy cell leukemia cells with vemurafenib and dabrafenib led to the dephosphorylation, as you can see here, of the downstream signaling molecule of BRAF, that is MEK1 and MEK2 and ERK. And another interesting observation was that the incubation with this BRAF inhibitor resulted after a few hours in the loss, as you can see here, of the airy projection, airy morphology by the tumor cells, and that only after having lost this property, apoptosis was observed. Stemming from these in vitro preclinical findings and the clinical reports showing transient activity of vemurafenib, the first oral BRAF inhibitor approved by FDA in BRAF mutated metastatic melanoma, where these BRAF inhibitors were first investigated among human tumors, we decided to start a clinical trial in refractory relapsed hairy cell leukemia. And this is the design of our first academic clinical trial that we called hairy cell leukemia PG01. And as you can see in this trial, vemurafenib was administered alone at the dosage of 960 milligrams twice a day, continuously for 2 months. And the dosage was that was previously used in metastatic melanoma. And this drug was administered for a maximum of 16 weeks to the patient. That is for a much shorter period than that usually is administered in metastatic melanoma, where the drug is given until usually disease progression. Toxicity was similar to that observed in a patient with metastatic melanoma. The most common adverse event were skin reaction and arthralgias, usually of grade 1 and 2, and demographic-driven skin tumors, which is a known adverse event in patients with metastatic melanoma, also occurred in our leukemia patient with two basaliomas and one superficial melanoma that were all treated with a simple excision. However, these findings also highlights the importance to have dermatologic consultation during treatment of very cell leukemia patient with BRAF inhibitors. I want just to show you one of the patients with the higher degree, grade 4 skin reaction due to vemurafenib 10 days after the beginning of the administration of this oral drug that was also accompanying an arthralgias, you see to the elbow, and that resolved after administration of low dose steroids. And another common events in this patient is palmar or plantar hyperkeratosis in a patient with hairy cell leukemia treated with BRAF inhibitors that is consistently reversible following drug interruption. Overall, response rate in this first trial in heavily pre-treated hairy cell leukemia patient, median of 3 previous lines of therapy, was about 96%, of which 34 complete remission, 61 partial remission. Median time to response was 8 weeks for both complete response and a partial response. This is an example of a bone marrow biopsy heavily infiltrated by hairy cell leukemia cells, here immunolabeled for the CD20 molecules using the immunophosphatase alkaline techniques that highlights in red the tumor cells. And here is the bone marrow from the same patient taken 8 weeks after bebunafen therapy. You can see there was a morphological remission for hairy cell leukemia, but immunohistochemistry could still detect about 5 to 10% of residual hairy cell leukemia cells in the bone marrow biopsy, indicating the presence, even after vemurafenib, of minimal residual disease. This set of images show the only patient that in the trial showed minimal response to vemurafenib and died of disease you can see this huge mass in the patient that by needle biopsy, we could be demonstrated to be pancreatic tissue. Here you see the glandula infiltrated by hairy cell leukemia cells that immunostained for CD19 and for annexin A1. So you can still die of hairy cell leukemia in the 2021, even having BRAF inhibitor available. And we had in a trial at least 2 or 3 patients that died because we admitted in the hospital with very advanced disease, and we were not able to enroll the patient in trial because they died before or earlier, before enrolling of opportunistic infection. After being affected by for 15 or 20 years by the disease. But this, I would like to draw your attention, this is not very uncommon, at least in my experience, to see a young patient with hairy cell leukemia in their 30s or 40s. They have about 40 years or more of life expectation, and they have to deal with this disease. So this is, I think, is a very important problem, even for a relatively rare disease like this one. So based on the presence of minimal residual disease in patients treated in the first trial with BRAF inhibitors, we hypothesized that relapse were due to the regrowth of the vemurafenib-resistant tumor cells, and that would explain that the overall relapse-free survival was about 19 months for patients achieving complete remission, and only 6 months for those achieving partial remission in the first trial. So if indeed the vemurafenib resistant tumor cells would exist while just after stopping vemurafenib or after continuing therapy with vemurafenib, we should expect that this residual, very small amount of hairy cell leukemia in the bone marrow hairy cell leukemia patient would have a constitutive activation of the MAP kinase pathway despite continuous exposure to vemurafenib. And this indeed is the case as shown in this bone marrow by immunostaining with an antibody against phosphotyrosine kinase that shows the presence of hairy cell leukemia with activation of MAP kinase pathway that is probably related to the fact that the microenvironment intervene and may be responsible for this activation and resistance to the BRAF inhibitors despite the continuous exposure to the drug. So based on this observation, we thought that there was the rationale to combine vemurafenib with rituximab in order to destroy the residual vemurafenib-resistant cell via an immunotherapy-mediated mechanism. This prompts us to design a second academic trial that we called early cell leukemia PG03 to treat a refractory relapsed early cell leukemia patient using vemurafenib plus rituximab according to this schedule that we published 6 months ago in the New England Journal of Medicine. This includes 2-3 cycles of the combination of vemurafenib plus rituximab and a consolidation phase using infusion of rituximab at the standard dose of 365-75 milligram per square meter, and all the protocol with a duration not longer than 12 weeks exposure to vemurafenib. So 1 month less than the 4-month exposure in the previous trial with vemurafenib alone. And we treated with this trial 31 patients who had received a median of 3 previous lines of therapy, and toxicity was that expected for either the vemurafenib, and I already mentioned about the toxicity of this drug, and the rituximab, you know, which is of course the toxicity of this drug. And there was, this is one major advantage of this drug, no myelosuppression of this combination, and complete remission was achieved in about 87% of patients, and remarkably, MRD negativity was recorded in about 60% of cases. And this is really an unprecedented result in a category of such evenly treated early cell leukemia patient. And these slides compares responses achieved with vemurafenib alone. Here, these 2 top slides, this is pre-vemurafenib, this is after 8 weeks of vemurafenib, about 5 to 10% of residual CD20 positive early cell leukemia cells. And of course, you can evaluate also the minimal residual disease even more with the higher sensitivity and specificity using the anti-BRAF monoclonal antibody, as compared with the images on the bottom, in which you have here pre-therapy bone marrow massively infiltrated by CD20 red tumor cells in red, and after only 1 month of vemurafenib plus 2 doses of rituximab, there was a complete clearing of the tumor cells, and this 79A positive residual tumor cell that you can see in the paraffin section are actually not hairy cell, but residual normal plasma cells. And this was also documented by MRD negativity evaluated by a allelic-specific PCR before and after 4 weeks. You see complete negativity of therapy with the combination of vemurafenib plus rituximab, and in this case, this was achieved after 4 weeks, but in another patient, for example, it was necessary to achieve MRD negativity to have also a consolidation phase with several doses, in particular 4 doses of rituximab. And this curve shows the impressive 85 relapse-free survival at 34 months of median follow-up in the 26 responsive patient. And here you have the progression-free survival that was 78% at 37 months of median follow-up, whilst the MRD free survival was 100% at 28.5 months of follow-up. And this is the relapse-free survival by prior exposure to rituximab. Interestingly, you can see that there is no difference between rituximab naive and rituximab exposed patients in terms of response to the RFS to following administration of this combo. Conversely, the relapse-free survival was longer in BRAF inhibitor naive patient as compared to the BRAF inhibitors exposed patients. In conclusion, as compared to vemurafenib alone, our first trial, the combo vemurafenib plus rituximab resulted into a dramatic increase of complete remission from 32% to 87%, in achieving MRD negativity from 0 patient to 63% of patient, in a shorter time to response, 4 weeks instead of 8 weeks, and in a marked improvement of progression-free survival in absence of myelotoxicity. So now we have probably a rationale to compare this chemotherapy-free regimen with cladribine plus rituximab, which is the standard regimen, I would say, as a frontline therapy in early cell leukemia, having as a primary endpoint the lower toxicity of the chemotherapy free regimen. We were planning to do this study, but because of the COVID pandemic, we were not able to run this trial because we thought it would be unethical enroll patient in the chemotherapy harm with cladribine and pentostatin, where you have a strong immunosuppression of T lymphocytes, and you may preclude the success of vaccination in this case. And this is the final slide where I would acknowledge all the researchers that in the last 10 years and clinicians participated to the early cell leukemia project that was started and run by our institution in Italy. And especially my colleague, Dr. Enrico Tiacci, who designed with me the trial, and all the chairing the organization, including Italian Association for Cancer Research and European Research Council and the Early Cell Leukemia Foundation from United States. They supported our work and allowed to achieve these results. Thank you very much for your attention.
Thank you, sir, for that wonderful presentation. Your discoveries, inventions, their applications, and how you have changed the story of hairy cell leukemia. Fantastic. We have some of our friends who would like to discuss some questions with you. We also have some from the audience. One is whether IGHV mutation should be tested in all patients of newly diagnosed hairy cell leukemia.
We didn't found any difference in terms of immunoglobulin mutations in patients treated with vemurafenib or alone or vemurafenib plus rituximab in our trial. It was not impacting the prognosis in this patient, at least with this kind of targeted therapy.
Right. Question from Dr. Neeraj Arora.
Thank you so much, sir. It is indeed a pleasure. I really enjoyed the talk. It was very learning. But few questions from my side. I happen to see both solid tumors and hematological malignancies, and you have BRAF. You just described BRAF being described both in solid tumors and in hematological malignancies. So do you see any relationship between these, or any sort of relationship between maybe melanoma having BRAF and a hairy cell having BRAF? Any?
What we had some cases of hairy cell leukemia that also developed melanoma, and in one case, in one patient, both were BRAF V600E mutated. So we thought about also about a possible germline mutation that could facilitate the occurrence of both tumors. But because of the rarity of the cases, we were not able to perform a study. As far as it concerns the pathogenesis, the mutation is the same, but the cells in which it's occurring is different. So the idea is that if you have a BRAF mutation in cells of a nevus or a melanocytes, you just develop the melanoma. If you have a mutation, somatic mutation in a memory B cells, you developed inherited leukemia.
And do you, what sort of molecular markers you use in addition to BRAF in a routine clinical practice? I mean, suppose a hairy cell leukemia patient comes to you. So apart from BRAF, will you do any other molecular marker or panel of maybe molecular testing to distinguish it from to prognosticate or to risk stratify, or only BRAF is what you do?
We use only BRAF, and to make is a very simple mutation to study because it's also there is a test which is used for melanoma, so every center can use it. And there is also a monoclonal, a commercially available monoclonal antibody directed against the mutated protein that, however, requires the Ventana machine to be detected. So we use these two molecular assays, especially because you find rarely other mutation in hairy cell leukemia. So I think hairy cell leukemia belongs to that kind of, let's say, stupid tumors that have just a few mutations, like chronic myeloid leukemia or acute granulocytic leukemia that just need a single genetic lesion to make the tumor. Very simple. And in that situation, you don't need additional mutation. So this is the kind of study we perform. And of course, we should also give credit also to the other simple immunohistochemical tests that we have, such as immunostaining for annexin 1, which is rather specific for hairy cell leukemia, or absence of monocytopenia, or presence of monocytopenia to distinguish, or intrasinusoidal pattern of infiltration. The hemopathologists know is very well in splenic marginal zone lymphoma. That, however, you can observe that also, I can tell you, also in hairy cell leukemia, rarely. So these are not really 100% specific. But I think all these very simple tests, you can make a correct diagnosis.
Do you use, can we use BRAF V600E for monitoring of hairy cell leukemia using techniques like droplet digital PCR in your routine clinical practice?
Yes, we are using that to increase the sensitivity of a very specific PCR, looking for DNA liquid biopsy. Because sometimes we have, for example, we had patients in which that achieve complete remission in the bone marrow, even by molecular techniques, but still have some splenomegaly. We have this kind of interesting patient. We don't know what does mean splenomegaly in this patient, whether it's is a reactive spleen or is a spleen that is still involved by hairy cell leukemia. And these patients have liquid biopsy positive. So probably there is a reservoir of hairy cell leukemia cells in the spleen. They may be not targeted by or maybe resistant to the vemurafenib because the microenvironment in the spleen is different from that in the bone marrow. So you may have different responses in different sites.
So can you use liquid biopsy also in these settings?
Yeah, we are trying to. We have no data yet published, but I can tell you in advance that we are investigating it.
And sorry, I mean, what time points would you recommend for this sort of monitoring if you have to do, a liquid biopsy based testing or a ddPCR based testing? Any specific time points in which this can be tested and gives you information?
We have to define yet. We have to define. We have just at the moment, let's say, standardizing the technique, and then we will decide which is the best time points to use.
Thank you. Thank you so much.
Okay.
Dr. Amrita.
Thank you, sir. And thank you, Dr. Falini. I really enjoyed your talk. My question is suppose we are doing a confirmation of hairy cell leukemia by flow cytometry. Do you think still we should go ahead for immunohistochemistry on the biopsy, considering that many patients are not in a affording situation?
Yes, I think that bone marrow biopsy is a basic examination to be performed in hairy cell leukemia patient. Is a critical examination, especially because, as you know, you may have a dry tap in the bone marrow aspirate. If you have pancytopenia, it's not easy to do the diagnosis by flow cytometry, even though flow cytometry should, of course, is a good diagnostic assay to be used, but the diagnosis should be always confirmed by a bone marrow biopsy.
My question is actually performing immunohistochemistry. We always, get a bone marrow biopsy along with the sample for flow if they are able to take out the marrow, since sometimes it's difficult, and we do it on the peripheral blood if there are representative cells, even. But, because immunohistochemistry itself adds to the cost. So if we have flow markers, then my question is, other than H&E, I mean the hematoxylin and eosine staining, is it really required to go for immunohistochemistry?
Yes, depending which kind of markers you are referring to with flow cytometry. If you are referring to the usual markers such as CD11C or CD103 or CD25, I don't think that these three markers alone can be absolutely diagnostic of hairy cell leukemia. And in flow cytometry, you cannot use the BRAF mutant because it shows inside the cells. And so I would be very much reluctant to base the diagnosis only on flow cytometry.
Thank you. Yeah, we are also combining the two, even if, flow cytometry gives us a hint towards the final diagnosis, but still we wait for the BRAF. And now we have started doing it. Thank you.
That's what we are doing too. Okay.
Thank you.
Dr. Parimal.
Thank you, sir. Sir, my question is when to do the MRD testing in the hairy cell leukemia patient?
Yes, the value of MRD testing on hairy cell leukemia needs yet to be established. However, there are a number of clinical evidences, especially the progression-free survival curves that suggest that, and even our trial that suggests that if you achieve MRD negativity, you can expect, I cannot say cure, but you should expect a much longer progression-free survival with these patients. I would recommend to perform this investigation at the end of the 3 months or 3 months of therapy with vemurafenib rituximab therapy, and again after 6 months.
And sir, which sample is better?
Certainly, I would recommend to perform MRD examination, MRD evaluation after 6 months following cladribine or pentostatin, because as you know, you should not perform a too early assessment after purine analogs, because this drug continues to act for many months, after up to 6 months.
And sir, which sample is better, peripheral blood or bone marrow?
Yeah, sorry?
Which sample is better, sir, bone marrow?
Okay. So I would say we are doing now both bone marrow and peripheral blood, just to compare, because we don't have an answer yet. So we do both of them to compare.
And sir, what is about that new cyclin D1 positive hairy cell? So hairy cell can be cyclin D1 negative, whether they can be BRAF negative or not.
I've seen cases of cyclin 1 negative. Usually hairy cell leukemia is cyclin 1 positive, but cyclin D1 is not very good marker, immunohistochemical markers for hairy cell leukemia. As you know, cyclin D1 is not due to translocation, but is due to amplification. And because not all tumor cells in cases which are positive express the cyclin D1, only a percentage of cells, and the positivity is weak to moderate, and even mantle cell lymphomas and other for example, other tumors that may have a morphology sometimes similar may express typically cyclin D1. So it's not a good marker in hairy cell leukemia, cyclin D1.
Thank you, sir.
Thank you. Some question from the audience. Will you consider variant hairy cell leukemia as an entirely different disease?
Yeah, I think it is. I think it is, and is molecularly at least 50% of cases, as I can tell you, are they carry the mutation of the MAPK2A1 gene that is encoding for MEK1. So in that situation, the correct therapy, the corrected molecular target therapy should be not with the BRAF inhibitor, but with a MEK inhibitor. And there are, however, still little experience with this condition with target therapy with the MEK inhibitor.
Right. Another question asked is the Japanese variant of HCL a distinct entity by itself?
I don't think it's hairy cell leukemia. I think what was reported in the past is T-cell lymphoma. Okay. But I asked several times to have these cases because I was very curious. This is very, very, very nice question you asked me, but I think most of these cases are not hairy cell leukemia.
Okay.
But I'm continuing to ask.
Right. What about the role of BTK inhibitors like ibrutinib in hairy cell leukemia?
There is a paper that was recently published in Blood from the Ohio State Cancer Group using ibrutinib in hairy cell leukemia. Ibrutinib in hairy cell leukemia is not as effective in BCLL. I don't know why. Maybe my idea, and I'm trying to demonstrate this, is that one of the components of the B-cell receptor, specifically the CD79B, is not strongly expressed. So we demonstrate this because we raised CD79B because we are very much involved now in raising new CAR T cells against B-cell antigens, and we investigate hairy cell leukemia, and the possibility of hairy cell leukemia is weaker than other B-cell lymphoma. So we think that probably ibrutinib may be not so effective because some of the components of the B-cell receptor are not expressed. You see some response, but it is not really optimal response, as you can see in BCLL.
Right. Will you consider splenectomy and interferon as obsolete therapies?
I think that this is a nice question as well. We have performed splenectomy in a few patients in which we had one or two patients, if I remember well, that went into MRD negativity in the bone marrow, but still continued to have in a large spleen. In at least one of these cases, there was hairy cell leukemia there. Right. So very interesting, very interesting.
You talked about CD22. In acute lymphoblastic leukemia, we have the ADC, inotuzumab, Vospansa from Pfizer, which
yes,
is
okay. Yes.
Any data on hairy cell leukemia?
Yes, hairy cell leukemia, as I can show you, as I show you in one of the slides, the complete remission rate is much lower than vemurafenib plus rituximab because it's about 41%, and the MRD negativity is only 30% of the complete remission. So very small amount of overall of the patient with hairy cell leukemia achieve MRD negativity, about 10%, as compared to 60% with vemurafenib plus rituximab. And you have always this problem. I don't know which is your experience with this hemolytic uremic syndrome that sometimes or a capillary leak syndrome, and we don't have the permission to use MOXE in Europe because it's not approved by EMA. Yes, it's approved. It was approved, but it was retired from by the company. So we cannot we cannot buy the drugs in Europe.
Any comments on why monocytopenia occurs and how is it so specific of this entity?
Very nice question, but I don't have an answer. I'm sorry, Dr. Agarwal. But very nice argument for research.
Right. Any other question from the faculty here? Dr. Tushar?
Yes, sir. Sir, do you think hairy cell leukemia, because of its presentation, it presents as a pancytopenia in the peripheral blood, and also it does not have any lymphadenopathy? Many, very few cases have lymphadenopathy, and they usually presents with pancytopenia and hepatosplenomegaly. They need a special category in the WHO classification of hematopoietic neoplasm, as did systemic mastocytosis, because they were initially with myeloproliferative neoplasm. Now they are separate. So these are also atypical lymphoid neoplasms, hairy cell leukemia, hairy cell variant, SLVL, with their presentation and the morphological features.
Yes, okay. So the WHO classification clearly, separate which is a distinct entity, okay, from a provisional entity. So hairy cell leukemia is a distinct entity of the WHO classification, and hairy cell leukemia variant belongs to the provisional entity, also called unclassified splenic B-cell neoplasm, that include, in addition to hairy cell leukemia variant, also red pulp splenic lymphoma. Why hairy cell leukemia does not involve lymph node is not known. Unfortunately, we don't have a knock-in mouse model of hairy cell leukemia because we think that these tumors is rising from memory B cells, but memory B cells is not an homogeneous B cell subset, is very heterogeneous. And my idea is that hairy cell leukemia probably rise from a special type of B cell memory cells. And now studies are ongoing by gene expression profiling, looking at gene expression profiling of hairy cell leukemia and comparing that with the different subtypes of memory B cells. And this may give us an answer. And probably is a question of homing receptors. So you may not have homing receptor for lymph nodes in hairy cell leukemia, but you have that for the bone marrow and the spleen. But to demonstrate that you need animal models, and we don't have yet that animal model.
Thank you.
Thank you, sir.
Any other question?
One question I wanted to ask regarding splenic diffuse red pulp lymphomas. How do you select those cases for your research or study? How do you define them and be able to work it around and say that it is a distinct entity altogether? Because we find it very difficult to define it altogether.
You mean how we define unclassifiable B-cell lymphomas?
No, within that specific diffuse red pulp B-cell lymphoma, that category.
That's specific. That's the most difficult to define, because as you can deduce from the name, like hairy cell leukemia is involving the red pulp of the spleen. So it's very difficult to distinguish morphologically, and I don't know. I don't have cases that were investigated with BRAF mutation, but this could be easily investigated by looking at the paraffin session for some of these cases using the monoclonal antibody against the BRAF mutant protein. And as far as I know, in France, they have investigated and they should be BRAF negative. And these tumors have different morphology with an increased number of plasma cells, and they have some cytogenetic abnormalities. And as far as I know, there are no specific genetic lesion that has been found in this tumor.
Thank you, sir.
To define this as an entity. So, as you know, it will appear this year a revision of the WHO classification, and hairy cell leukemia and this variant will not change as compared to what we know in the 2016.
Thank you, sir.
Thank you. So is that the last question? Anything else? None then. Dr. Falini, extremely grateful to you. Thank you so much.
Thank you very much to you for your attention. It was a pleasure to be with you today. Okay, as always.
Wonderful day ahead. Thank you.
Okay, bye-bye. Bye-bye.
Good night to everybody from India.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.